Hello, everyone. Association for Scientific Research for the IRIFIV-AISRG group would like to greet you all. I'm Dr. Haida Al Musa, PhD in Laboratory Clinical Reproductive Technologies and Reproductive Physiology, a clinical embryologist and assistant professor in High Institute for Fertility Diagnosis and Assisted Reproductive Technologies in Baghdad, Iraq, a member of Scientific and Administrative Committee of the Iraqi Fertility Society. I worked also as a scientific consultant from some IVF centers in Baghdad, Iraq, and a member of IRIFIV-AISRG group. Again, best greetings to all. On behalf of IRIFIV-AISRG group committee, welcome to the International Conference of the Annual Exam Worldwide Online Meeting in the Association for Scientific Research for the IRIFIV-AISRG Reproductive Medicine and Endometriosis Research Group. The conference for the first annual exam, which includes the Department of Gynecology, Obstetrics, and Senior Clinical Embryology. The scientific program within a theme called Research Seeks the Focus by Science. Today is the day one of the conference, which includes the session A that represents the clinical reproductive medicine within a line of fertility, explaining the unexplained endometriosis and endometrial disorders. The session moderator will be Professor Dr. Iman Al-Jundi. Dr. Iman Al-Jundi, Doctor of Medicine from Zagazig University in Egypt. She has a PhD from Maastricht University, the Netherlands, Holland. She's a professor in obstetrics and gynecology from Zagazig University and clinical director of Fahm Fertility Center in Egypt. She's the Secretary General of Egyptian Foundation for Reproductive Medicine and Embryology, IFRI, and the Director of Egypt IVF Registry. She has authored and co-authored many research studies published in both national and international journals and has been a reviewer for many prestigious journals. Her research interests include ovarian reserve, optimizing controlled ovarian stimulation protocols, optimizing the outcome of frozen cycles, and fertility preservation. Doctors and scientists save lives, but their role goes for beyond than just being healers and life savers. They are the ultimate life givers, making miracles happen, the form of healthy babies to the couples that have otherwise lost hope at conceiving. Welcome again, Professor Al-Jundi. The floor or the mic is yours. Good luck to you and to all speakers. Professor Iman, the voice is yours. Professor Iman, do you hear me? Professor Iman.
I think some network issues.
Okay, sorry, there have been misconnection for a second. Thank you, Dr. Haidar, for your presentation. And it's my deepest pleasure. You hear me?
Yes.
Everyone hears me?
Okay, Professor. The voice is clear now.
Okay. You hear me?
Yes.
Yeah. Yes.
Okay.
Okay. It's okay. It's okay.
Okay.
Okay, Professor. Continue.
Qu'elle ne s'entend pas.
I think there's a problem in the internet with Dr. Iman. The internet problem is always different areas.
If you want, I can begin.
Okay, Dr. Mohammed, you can begin the session.
Please.
Good luck.
Thank you. Thank you. And I'm so happy to and honored to to welcome you to our first meeting. And I hope this is the beginning in a long and fruitful collaboration that will improve our shared experiences. أهلا وسهلا ومرحبا بكل الأصدقاء والإخوان والأخوات الذين التحقوا بنا بهذه الجمعية، وأتمنى أن تكون هذه بداية للعمل الجماعي الذي يمكننا من تحسين مستوى طب الإنجاب في بلادنا إن شاء الله. Je vais le dire en français aussi. Chers amis, bonjour. Je suis très content de vous voir parmi nous. Et ce matin, et de lancer avec vous cette aventure et de cette association de recherche scientifique qui va nous permettre d'échanger et de partager nos expériences. Pardon. I'll share. Voilà. Okay. It's good. You see. Okay.
Encore.
Excusez-moi.
Dr. Iman, can you continue?
Yeah, now, because, sorry for net error. I had misconnection, okay?
Okay, no problem.
Good.
Okay?
Yeah.
Good?
It's okay.
Yeah. The topic I would like to share with you today is the role of endoscopy in explaining the infertility or sterility. I'll use the word infertility because with it there is more hope. When a couple can't procreate, we start looking for the etiologies. As you know, 30% of causes are feminine, 30% male causes, and 30% combine both, and 10% remains unexplained. Those 10%, it was what interests us today. As well, you know, for a pregnancy to happen, we need the following: a sperm and oocytes of good quality, a clear way for sperm to meet oocytes, receptive endometrium where the embryo can implant and grow, and the genetic quality of gametes is essential and primordial. How to assess the uterine causes of infertility? A simple sonography or stereo-contrast sonography, HICOSY, will show us the state of the uterus. Stereosalpingography will show the state of fallopian tubes. Sometimes we need an MRI to confirm suspicions. When everything seems normal and still we don't have pregnancy, then there is a problem and we need to investigate further. That's when we should think about endoscopy. Endoscopy will help us to explore two areas, the pelvis and the endometrium. In the pelvis, we'll look through laparoscopy at mechanical and chemical obstacles. In the endometrium, we'll look through hysteroscopy for inflammatory diseases. Hysteroscopy. We know that 2 to 3% of infertility is uterine cause, and half of these causes are intracavitary, including chronic endometritis. Chronic endometritis is responsible, as you know, for 30 at 60% of implantation failure. And hysteroscopy, this is the gold standard for diagnostic intrauterine diseases. Macroscopically, we find a congestive petechial or hemorrhagic aspect of endometrium, and we must do biopsies. Chronic inflammatory phenomenon is due to microorganisms, sometimes to immune reaction. And the genital infections, mainly anaerobies. And we find in 60% of cases of endometriosis, chronic endometritis. We treat it with antibiotics, 3 weeks, with steroidal anti-inflammatory drugs, and we don't forget about the husband. The laparoscopy. Laparoscopy, as we see in this video, we have inflammations, adherences, and the ovaries are completely covered. All of this is due to endometriosis. However, we can see that the fallopian tubes are functional. So if we rely on the hysterosalpingography only, we'll misdiagnose the case of infertility. Again, this case shows us the importance of endoscopy. As you see, there's so many adherences and inflammatory. Adherences. The etiologies, the adherences inside they could be post-surgical, often after myectomies or different kind of pelvic surgery. They could be post-infectious. Most of them is either chlamydia or tuberculosis in our countries. Sometimes endometriosis can be the cause. As you see in this video, we see that it's important to look all around, especially to the liver. Here we have Fitzgerald syndrome that shows us that a chlamydia infection. And as we see, these adherences are thin and form a complete peritubo-ovarian obstacle. During surgery, we perform the adhesiolis. Laparoscopy will help us to establish a diagnosis and classify the adherences and decide on the therapeutic course of action. This is the classification. This is a French classification. Now endometriosis. We'll talk about endometriosis. As you know, 1 in 10 women have endometriosis, and endometriosis is a disease which endometrial cells migrates outside the uterine cavity and form implants that colonize in distal tissues. It's old, it's discovered in 1860 and become more detectable with the advent of endoscopy. You see, in England, in United Kingdom, to get diagnostic need more than 7 years. and 15% of fertile women are affected by endometriosis. The clinical and anatomical manifestation. Clinically, endometriosis has two big symptoms, pain and infertility. And sometimes we can have pain without infertility, and sometimes infertility without pain in 4 to 7% of cases. And lesions, anatomically lesions, it's endometriosis lesions can be superficial, deep, or with or without cysts and adherences. And we know that endometriosis is an inflammatory disease. It's believed to act on 3 axes: angiogenesis, elevated levels of inflammatory components, and cell proliferation. All of these elements are estrogen dependent, with the elevated cytokine, as you see. And the effect of endometriosis on oocytes, will have a poor oocyte quality, increase of meta-1, and there is cytokine, macrophages, prostaglandins, and reactive oxygen species in follicular fluid, and disorder of endocrinology. As you know, the abnormalities of prostaglandin and disorder of humoral immunity and cellular immunity, all this will lead to abnormal chromosomal misalignment and DNA fragmentation with the aneuploidies in the cellular, in chromosome and is in oocytes. How to put a diagnosis? The part of the endometriosis diagnosis is importance of the vaginal touch during the clinical exam in period. We do sonography, blood tests, and MRI, and all of these exams lead to us to suspect endometriosis, but biopsy and preferably removal of these lesions for histologic confirmation are necessary for the diagnosis. Laparoscopy will allow us to establish a real diagnosis by performing biopsies and have an exact staging of endometriosis. As you see, we use American Society for Reproductive Medicine revised classification. In this video, we'll see the elements, the endometriosis lesions on a ligament utero-sacral, and there is the left ovary. And this one is a deep lesion of endometriose on the left ligament sacral, utero-sacral ligament. With that, as you see, the tube was functional, and I used a simple surgery tool that's easy to find in all operation rooms. It's a monopolar electro cutting. I drew the lesion, and as you see, we are making a shaving on a rectal mucosa. Rectal mucosa is uncovered. And the first, I inject a serum under the peritoneum to keep away the noble structures below. And this one is on a bladder, as you see. In our experience, personal experience, in 1 year, there's 332 cases of unexplained infertility. Endometriosis diagnosis was in 57%, and spontaneous pregnancy after 1 year was about 36% without IVF, just surgical treatment. So if there is an infertility, there is a cause. We must re-examine the file and review all the results, and endoscopy can find and treat mechanical etiologies as well as endometriosis. And we take into account the age of patients and duration of infertility, and we staff all files. Thank you. Thank you very much. Yeah.
Thank you, Dr. Zarqawi, for your excellent presentation.
Thank you.
You hear me?
Yeah. And you? Oui. Yeah.
Okay. Okay, you hear me? Okay.
Okay, me, I hear you. Yeah, no problem. No, I don't hear anyone. Bon. Mustafa?
Dr. Zarqawi, you can proceed your presentation.
Thank you.
Thank you.
Perhaps I could start next.
Yes.
Yeah, just as soon as you're ready, just give me the go ahead. We need to save time. Thank you.
Okay, welcome to Dr. Yaqub Khalaf. Dr. Iman, you have problem with connection in Zoom. You continue, Dr. Yaqub Khalaf. You are welcome.
I need to be able to share my screen. It's not allowing me. Can someone at your end give me those privileges?
Okay.
Thank
Good.
you.
Before it was.
Can I now? I'll try again. I can. Thank you. Okay, so yes. Okay, we hope we can get Dr. Iman back with us, and I am on my way. Can you see me? Can you see my slides?
Yeah, we see you.
Yes, I am very
Good.
sorry for my terrible voice, because as you can see, I've got bad cold, even though I had the flu vaccine and I have the badge to show that I had it. But anyway, I will try my best not to bore you, but for any particular forum like this one, addressing research honesty and integrity is of paramount importance. We cannot launch into research without making or taking note of what matters to research honesty and integrity. The society expects us to be able, through science, to solve a problem. Whether it's fertility or infertility or medicine, it is our responsibility. Now, the society cannot trust us if our work is not trustworthy and if we can't trust each other. If we do that, we will be seen as just another professional group. It could be in any walk of life that are interested in furthering their career, making money perhaps, and not particularly interested in society's problems. So integrity in medical research is extremely important. Integrity is about the performance of research to the highest professional standard or highest standard of professionalism and rigor in an ethically robust manner. And sometimes these things are forgotten because you just go and ask the patient if you did, but there is no paperwork to show that you really have explained and the patient got you her truly informed consent. That's ethically untrustworthy. Misconduct is when you don't follow those principles. If you don't have the high standards of integrity and ethics, and you ignore them because you are keen to publish, then that is misconduct. I can't say that research misconduct, please bear with me with my flu. I can't suggest that research misconduct is limited to certain continent or certain country or certain people. Research misconduct is experienced globally, everywhere. Name a country and I will tell you there will be some element of research misconduct, because there will always be bad apples in any culture. If the environment where we work in has a different attitude to what we call dishonesty, if it shows zero tolerance, when the research shows that it's not trustworthy, people pay the consequences, this will not propagate. But if they turn a blind eye, this will flourish and will lead to more bad research. So, as I said, research misconduct, and when you don't follow the integrity. How you not follow the integrity or the high standard? You can fabricate. That is the worst possible scenario, where you imagine that you had the study, but you, rather than doing it in the field with the ethical standard and the ethical approval and the recruitment standard and the witnessing and everything else, no, you do it in your own office and send to the publication. And or falsification. You did a little bit and then you made the rest. Or you use somebody else's work to claim it is yours, even if it is the introduction. There is some pioneering work that had to be retracted because the author helped themselves to the introduction from somebody else. So they plagiarize this and undermine their reputation, the hard work that they did, and the reputation of the institution. So only through this assessment, we will be able to tell what is fake from what is fact. What are the drivers of research misconduct? We need to ask ourselves, why are we doing research? Are we doing it to explore new ideas? explore new horizons? Do we also do it because we would like to develop novel solution and prove they work, but legitimately solve unsolved problem? That is the strap line, the party line. But unofficially, some of us will do to publish paper because it sounds prestigious. I publish a lot. Yeah, but this a lot has to be associated with honesty and integrity. To go to conferences, it is very good for the ego to be invited to the conference to publish your work or present your work. If it's honest, that ego should be truly massaged. But if it is not, then people should really look deep into themselves. Attract funding. You do research, you need to have track record, then people can trust you with their money. To enhance your CV for your next job, to secure academic industry or academic or industry job, or maybe to impress your people. Now, research is expensive. You cannot do research like you go to McDonald's. Research takes a lot more time, more effort, more money, more governance for it to be credible. You cannot do research as an individual and claim credibility. You need to have a team, and you need to have the controls and the checks and balances within the research to protect the research, protect you, and protect patients. Now, people will say, but research is expensive. If we ignore research because it's expensive, let's have a go at disease because it's much more expensive. Otherwise, we will not progress. Research misconduct is unusual, but it is not rare. When you look deeper, you will find the true picture. The incidence of research misconduct is usually gleaned from how many papers have been retracted, how many papers there is concern being raised, and that increases over the time. Unfortunately, it's increasing exponentially. It is over the years, and that's about maybe 10 years ago. Look at the trajectory. It's going up. Whether it is fraud, as in red, error, or plagiarism, or duplicate publication, it is all going up. And here is the same percentage of retraction going up. It's going exponentially up beyond belief. It's not only one country. Look at it happens, fraud or suspected fraud happened in the US, in Germany, in Japan, in China, in UK, in India, in any country, you name it. Plagiarism can happen anywhere. Developing or developed. Duplicate publication can happen anywhere, developing or developed. How do medical journals deal with research misconduct? They apply the code of publication ethics. If they have a little bit of honest error, they ask for correction. But if there is incorrect author list, they also seek correction. But if it is really a reason to express concern, like inconclusive evidence or publication misconduct, evidence of that finding are reliable, but author institution will not investigate. And one of the common publication misconduct, when we have people having their name on publication they don't know of, just because it is a gift, that's got to stop. Really, it is not the way, the honest way of doing it. Or an investigation is underway, but results not be available for some time. Clear evidence that findings are unreliable. Then you talk about retraction. Plagiarism, falsification, all of that is a cause for retraction. So concerns, that's an example of raising concern. Back in 2000, nice Japanese people expressed their concern about one of their own, a Japanese author. And what did they say? They say reported data on this medication by so-and-so are incredibly nice, which is a code for they are too good to be true. They need to be investigated. Okay, so people investigated. What happens? It took years, and then that person has been involved in 183 randomized controlled trials that were retracted. So it is a small thing that leads to bigger ones. Retraction is the worst punishment because you are really branded dishonest, particularly if it's substantiated, and that is not. It could end academic career in some respectable institution. One recent analysis that focused on articles contained in PubMed database found more than 2/3 of retraction were due to misconduct. That is falsification, fabrication or plagiarism. And it is not the privilege of small unknown journals. Even big journals have papers retracted due to fraud. The most common example is this one in the Lancet about the measles, mumps, rubella vaccine, and other paper, Lancet, Science, Nature, Medicine. So it can happen. But unfortunately, between raising concern and retraction, it could take 10 years. It is much quicker now. And the sad thing is, those retracted papers, they continue to be cited. So they pollute the literature. So that is a plague that need to be weeded out from the beginning. Look at coronavirus. It's only been around less than 2 years. How many papers have been retracted on COVID alone? Any guess? Some of you will say 10 or 15, 160, and we're counting. In 2 years, and in a high-profile journal by high-profile people, and unfortunately, the mistakes are school children mistake that uncovered the falsification or fabrication. So what is helpful? You cannot do research without proper training. You cannot do research or read research even without understanding the context. And you need to always maintain impartiality. Everybody is adamant that their intervention must prove positive result. That's wrong. You are examining it. And if you examine it objectively, if it does prove or disprove, it is as valuable as each other. So appropriate resources, teamwork, collaboration, peer review, and open-mindedness. It doesn't have to prove what you had in mind beforehand. So what's very helpful is to read the practical research guide for health researcher by one of the research icons in the world. I don't think I've seen many people of his stature or gravitas and his pure concern about humanity in what he teaches and what he conducts and what he lectures. And that's why he is in a special place in the community of Obs and Gynae for his humanitarian approach. What is not helpful is the wrong approach. By the way, the previous guide is available online free. So what is not helpful is to have the wrong approach. What is the problem with research? Anyone can do it. Let's just make up something. Lack of training. Yeah, again, just do it. You get someone telling you, but there is no control group. Oh, we will give you a control group after you have submitted for publication. That's lamentable. Yeah. Lack of understanding, lack of consultation, preconceived idea, doing away with proper methodology, and having great confidence in observation and observation studies. If we cut many corners when we do research, our research will never have an edge, and that is true. And it is important to subscribe to this. If we decided to do research or to do anything, we should adhere to this principle. Whatever is worth doing at all is worth doing well. If we decided to spend time on something, spend it on doing something very well. Now, I'm not fond of Tony Blair, but this is his slogan. A long time ago, when he was in charge of Labour Party, he said we should be tough on crime and tough on the cause of crime, which is absolutely spot on. We should be tough, not on research misconduct, but on the root for research misconduct. How we can reduce the root for research misconduct, we should not put undue pressure on people to publish and to produce when they don't have the resources. We don't also make it a prerequisite for academic promotion to publish in international journal when we have not given them the research support to enable them to do a proper job. Okay, inadequate research governance. If people can do whatever they do without check, then it's not a great idea. And I, just for the sake of time, here is my analysis. This where things can go wrong. There is pressure and there is opportunity to do what's something wrong, and you will always rationalize it for yourself. But everybody's doing it. But I have to keep up with my classmates. I can't fall behind. These are the basis for research misconduct. Now, if you look at this, when you have pressure, it depends on the culture. A good culture should not put researcher under pressure. If you have control where people are asked to provide the research data for assessment, then probably the opportunity will not be taken to conduct to research misconduct. If you rationalize, you have to subject that to your own values. Are your own values inclusive of honesty and integrity or not? And this extends to the fraud triangle, also opportunity, rationalization, or incentive. People are paid to do international or to publish international research. If you give them incentive, you are giving also a push to be fraudulent, not just to have research misconduct. When you look at randomized control trial, which is by far the gold standard, the decent gold standard for any intervention, there is a fraud alert that is being suggested in European Journal of Obs and Gynae to help you tell what good research from what not so good research. When you find the trial not registered in clinicaltrial.gov or any respectable research registry, you should wonder why. When it is registered retrospectively as afterthought, you need to ask why, and that raises the highest index of suspicion. When the number of authors is 1 or 2, you cannot do proper work when it's 1 or 2. You just can't, okay? And short time period between the trial completion and publication. That is half-baked job. You need some proper analysis, proper cleaning of data, proper drafting of the paper, which could be up to 12, 13 drafts sometimes. Implausibility of recruitment. When you say your recruitment for something rare, 800 patients, which planet are you on? Some institution could take 5 years to recruit this, and you recruit them in 6 months, you have to explain, and so on and so forth. So the other issue also now that it's become mandatory. If you claim honesty in what you did, you have to be able to provide raw data when asked. And most of decent publication will say now, request for data collected for the study can be made to the corresponding author and will be considered on an individual basis. Additional study-related documents are immediately available and can be requested from the corresponding author. That reassures that everything is transparent, people don't have anything to hide, and you have it to check it out, rather than say, no, I'm not giving you. Who are you to give you my raw data? I'm not giving. That's just not the way. And I have examples where people were challenged and turned this into opportunity. They turned the raw data to the editor and to the publisher. They proved the veracity of what they did, and they had received a due apology. Cochrane Library, we had a webinar recently, some of you may have attended, and it is clear that problematic studies will be labeled before included in any Cochrane review. And that will cause a problem, because if you have your trial as problematic, you'll have explanation to do. And you don't want to contribute to the talk that I gave, where everybody assumes now research is fraudulent until proven otherwise. That is almost established. Those who are interested in reading about research integrity and fostering it, this document is available online for free. So you can get it and have a read. So these are the conclusions. Research is important, and good clinical research skills, something you can acquire, and research training and resources are essential. Research planning and monitoring are important. Peer review is extremely helpful. Cutting corners undermine research quality, and research under pressure will almost always be compromised. The end in research or in medicine should never justify the means. Just because you are keen to get promoted does not mean you should do that. But also my final thought, be aware, a word of caution. To who? To the readers. Don't believe everything you read, whether it's electronic or in the library. To the author, beware, your work will be under scrutiny. And if it is not watertight, you will be questioned. To the patients, when you are given advice, you need to not to take it from Google, but take it from expert who believes in evidence-based medicine. Thank you very much.
Thank you, Dr. Yaoub, for excellent presentation as usual. We will keep you to the end of the session, or you have?
No, if you have a question or two, because I have patient and also I have a flu. Thank you. Yeah.
ألف سلامة يا فندم.
Allah salam.
Any questions for Prof. Yaoub, because I think he has to leave. Exceptionally for Dr. Yaoub.
Thank you. Appreciate it. Thank you.
Okay. Any questions from the floor?
It was honest, so no question.
Thank you.
No, I have one question for you, Prof. I have seen
please.
the percent of defects in researches. The most common was in US, as I have noticed, I think.
No, yeah, but that is, we always comment, not because the US is fraudulent, but
No, no,
because,
I mean
no,
this.
I'm just saying it is proportionate because the US is the largest provider of research in the world.
Right.
So when you provide more, you will have more under this item. Yeah.
And this proportion also is increasing across years, or it started high and it's declining for US
No,
in general?
I don't think it is declining. All of that is increasing, and we see it day in and day out. Yeah, and some people may not do it intentionally, and some people do it because they invested in some intervention for years and they would like to see it being marketed. So they will just, cut the corners and put it, and there is a bit of a lesion. And by the way, the journals, editors, and the publishers are equal partners in research misconduct, because if they do proper peer review, if they do not accept research that appears to be not good from the outset, we will not be here discussing it.
Yeah, totally agree. Thank you, Dr. Yao.
Pleasure.
See you later,
I
inshallah.
wish you a great meeting. Thank you.
Thank you.
Bye.
Okay, bye. Our next speaker is Dr. Rita Santwani, MD. She's member of the Association for Scientific IRIFIV-AISRG, Reproductive Medicine and the Endometriosis Research Group. Dr. Gynecologist, carries more than 20 years extensive experience in obstetric gynecology and fertility, speaker in more than 1,000 webinars. She has written more than 200 articles and for various health journal and newspaper. She has various awards and recognition for her significant contribution in health and social care service. She's going to address endometrial preparation before third embryo transfer. Please, the floor is yours.
Yeah. Thank you, madam. Thank you so much, Professor Iman. And from our India, we do the greeting that namaste to everyone, or I can say salam to everyone. So now I'm starting the sharing my screen. And thank you. Please make me host. I'm not able to share my screen.
Can you continue now? Go ahead.
Yes, now it's working. Now it's working. So thank you, Dr. Mustafa, for inviting me here. Yes. Yeah. I hope my slides are visible, madam. Is my slides are visible to everyone?
Just assalamu alaikum.
Yeah, assalamu alaikum. Yeah.
Yes, you're welcome.
Okay. Yeah. So the topic which I'm going to discuss today is the endometrial preparation before the third embryo transfer. I think this is a very, very important topic. Those all who are doing the IVF practice, so this is very, very important. So I tried to make my presentation little simpler also. So as there is a famous quote by the Professor Albert Einstein, do we understand? If you can't explain it simply, you do not understand it well enough. So friends, as we all know, the hard facts, the healthy seeds is not enough to get a healthy sapling unless it is grown on the fertile soil. Similarly, the healthy embryos needs the receptive endometrium for successful implantation. So, as we know, the implantation depends on the embryo quality, endometrial receptivity, and of course, the transfer efficiency. So, regarding this window of implantation, what are the potential for personalized embryo transfer? We can see one by one for the human pregnancy to occur. A normal embryo must implant in the endometrium, and for this has to be happen, the endometrium must be in the receptive state. With significant improvements in the cryopreservation technology, vitrification, the number of frozen embryo transfer IVF cycles are increasing and may surpass in numbers and success rates compared to those of fresh cycles. A small video I've kept for the endometrium. So here we can see once how the movement in the endometrium. So endometrium lining in IVF. So the first successful pregnancy occurred following the frozen embryo transfer has been reported in 1983 by Progesterone. The cryopreservation of embryos has become an integral part of ART programs, increased dramatically. The trend towards transferring the fewer embryos after a fresh IVF cycle, and the studies have shown that it is an improved laboratory techniques will give the good results. So friends, the study has been presented in the Fertility Sterility Journal that an endometrial thickness of 9 to 14 mm is associated with a higher implantation and pregnancy rates as compared to the endometrial thickening of less than 7 mm. So there are a lot of studies have been shown regarding this. So if the endometrial thickness is less than 7 mm, how it affects on all the implantation rate, the clinical pregnancy rate, and the ongoing pregnancy rate, and the live birth rate. So the receptive endometrium requires the estrogen priming, need for the endometrial proliferation and development of P4 receptors, the time-related progesterone-induced secretory changes in the endometrium, while the other molecules have also been reported. Among this, the laminin type 4, collagen, integrin, and so many other factors have also been reported. So now for the optimal endometrial preparation for FET cycles, it demands the different endometrial preparation protocols, progesterone support, identification of receptive window of implantation of embryo transfer. These are of most important for ensuring the best results. The success key points in performing FET is the selecting of the proper embryos used for FET, and accurate synchronization of the endometrium and embryos is the key of performing the frozen embryo transfer. So a very important point among this is the age of the embryos after thawing corresponds to the age of the endometrium on the date of the embryo transfer, and the sufficient luteal support is needed. So now what are the different protocols for this endometrial preparation? So friends, we can take one by one the natural cycles or the programmed cycles, or where the ovulation induction has been used. So according to these methods, either with the functioning ovaries, we can use any method, while in the cases where the quiescent ovaries, means where we are using the donor oocyte recipient with ovarian failure or due to some other reasons, only the hormone replacement therapy with estrogen and progesterone. And there are many different protocols has been reported. So among FET, it is only feasible for the women with regular cycles and proven ovulation. In normally ovulating women, the protocol of choice, the simplest method, endocrine preparation of the endometrium, is achieved by endogenous sex steroid production from a developing follicle. While among this true natural cycle, it meets the regular cycles and proven ovulation, involves the frequent monitoring of urine and blood LH levels, early luteal progesterone levels, and the ultrasound monitoring of developing dominant follicle. For optimal FET results, the precise identification of the LH search. Now, what are the disadvantages has been reported with this? Even in women having the regular menstrual cycles, ovulation may not occur always. Problem associated with the detection of a spontaneous LH surge, variation in timing of its occurrence between the cycles and between the patients. And in order to assess the LH levels correctly, the determination should be performed at least daily and preferably twice a day. LH urine kits has a large variation in the thresholds, which involve the risk up to 30% of false negative testing and are often reported by the patients as being difficult to interpret. Now coming to this modified natural cycle. So friends, here, now what to overcome the disadvantages of the LH monitoring, administering the SCG to initiate the luteinization involves the ultrasound monitoring of the developing follicle, measurements of the endometrial strips, of monitoring of serum hormonal levels, followed by 5,000 international units of HCG when the dominant follicle is more than 17 mm and the progesterone levels are low. So here we can see the same what I have spoken. It has been presented by the so many studies. So now what are the advantages and risks associated with this? With the advantages, the less ultrasound evaluation due to the HCG administration compared with true natural cycle frozen embryo transfer. So less burden to the patients and doctors. But now what are the risks expected? Unexpected ovulation, accurate planning of the embryo thawing and transfer is not possible, and the cycle cancellation has been reported 7 to 12%. And sometimes the difficulty in ensuring the timely thawing and embryo transfer. So now, what's the role of this luteal phase support in natural cycle FET? So the different studies have come. Some authors have reported that it is not required, while some studies have shown, there is one study has shown that the higher live birth rate in the patients undergoing the true natural cycle frozen embryo transfer with luteal phase support. So there are two schools of thoughts, some studies in the favor of that and some studies are not. So now for the, what are the methods available there for the preparation? So friends, there are several preparation methods. The exogenous estrogen is administered early in the follicular phase in order to induce the endometrial proliferation and inhibit the spontaneous ovulation with progesterone added days before the embryo transfer. So now coming to this programmed artificial cycles, it involves the suppression of natural menstrual cycle with or without the use of GnRH agonist. This requires the exogenous estrogen for the proliferation of the endometrium while suppressing the developing dominant follicle in addition to progesterone replacement and to achieve the adequate secretory changes in the endometrium. So among this, what the protocol has been mentioned by Paulson, that estrogen administration on day 2 or 3 of the cycle, either by incremental or fixed levels, up to 3 tablets until the endometrial thickness on ultrasound has reached approximately 8 mm, and then add of the progesterone 400 milligram PD, and for the number of the days proportional to the stage of the development of the embryo being transferred. So it is the most convenient and respect to limited the monitoring requirements and ease and the flexibility of scheduling. So this protocol is good in the patients with irregular cycles. So now what are the key points among this? We know the endometrial thickness of 6 and showing of triple line is favorable. Endometrial development is unaffected by the length of the follicular phase. No adverse effect of reduction or duration of exposure to estrogen to 6 days or an increase up to 35 days has been reported. So friends, here we know and studies have shown the endometrium is affected by either incremental or fixed estrogen levels, even in the supraphysiologic change. So now coming to the other protocol, the estrogen and progesterones without GnRH agonist used in the females with the remaining ovarian function. Amongst the method what has been prescribed, the estrogen, which helps in the proliferation of endometrium while suppressing the development of dominant follicle. So here the different protocols and methods have been reported: the oral estrogen or the transdermal patches, subcutaneous implants, and vaginal rings or tablets. But here in India, mostly we are using the oral estrogen, and of course, in some patients, we are giving the transdermal estrogen gel also. So here, as we know, the cycle here you can see from the ecto cycle. So the estrogen has been started from the day 2 of the menses and continue, and progesterone has been added just before the transfer. So the progesterone, the aim is to initiate the secretory changes. It is available either in the form of the oral tablets or the intramuscular or the vaginal suppositories. Yes, the progesterone injections, both the aqueous preparations are also available these days, or in some patients we are using the progesterone intravaginal gel also. So while the studies have shown no difference in the pregnancy rate between the vaginal and intramuscular progesterone based on the patient and doctor preference. So here, what the protocol suggests with the estrogen from day 2 or 3 of the cycle, 3 or 4 tablets, while with the ultrasound, if we see the thickness up to the 9 mm, then the addition of the progesterone. And here, as you see, for the embryo transfer, the blastocyst, the transfer on 6th or 7th day of progesterone, or on the day 3 or morula, the transfer on the day 4 of the progesterone. These are the usual protocols what we are following, and the luteal phase support. So here the different studies have been presented regarding the use of the estrogen. So now what is the protocol suggesting the estrogen progesterone with GnRH agonist in the females with remaining ovarian function? So there are the different methods regarding the use of this GnRH agonist, 37.5 mg, since there's a mistake, that is 37.5, in regularly menstruating, it is given on day 21 of the cycle. And in oligomenoric from day 1 of the cycle, and after 14 days, estrogen is determined and estrogen is started as before. So the different protocols has been for the recipient in frozen thawed embryos. As we have seen, this is day 20 when it is started. And on the from the menses, the estradiol gel or tablet. And as we have just discussed, that before the transfer, we have to start the progesterone. So the studies have shown this has taken from the Davros and Pados, the endometrial development during the frozen thawed embryo transfer in the woman with irregular and ovulatory menstruations, development during oocyte and embryo donation with poor or absent ovarian function, absent management of thin endometrium mini-RT. So the studies have shown that estrogen can be administered either in an increasing dose or the constant dose from the beginning of the menstrual cycle. So the doses what has been recommended is up from 6 mg to up to 16 mg has been recommended. So studies have shown that the oral is having a most commonly used and the transdermal route also giving the steady levels of estrogen and most of the physiological even E2 ratio. So as I just discussed, the different formulations are available, the oral, the transdermal gel and patch. Our India is being a tropical country, we are using mostly the oral, and in some patients we are using the transdermal gel in these days. Transdermal patches, I have no experience with that. So here, just as I have discussed, yeah. So among this, oral estrogen increases the hepatic production of TBG, SHBG, triglycerides, and HDL and clotting factor. So it is minimally increased by the transdermal estrogen administration. So friends, in these patients, if the problem of such kind is reported, we prefer the transdermal. So the studies have shown the endometrium may respond differently to a different combination of the estrogenic compounds. So regarding this vaginal administration also avoids the metabolic effects, but in some patients with vaginal estrogen, the local irritation and discomfort has been reported. And suppose if in these patients we are giving the vaginal progesterone also, that it may inhibit the absorption of vaginal progesterone, which is needed for the development of the endometrium. So there are different studies with the different components has been reported, which are affecting on the estrogen receptor, alpha and beta. So different preparations are available. So among this transdermal estrogen, we can see the studies have shown the more physiologic concentration of estradiol and estrogen metabolites is found with an estradiol-estrogen ratio similar to that of the premenopausal woman with the use of transdermal preparation. So there are different studies with the use of different preparations. This I just discussed. Yeah. Among this, the oral administration of this estrogen, the studies have shown that estrone is a weak estrogen with the lower binding affinity for both alpha and beta estrogen receptors. So studies have shown that with the transdermal route, suggested to be the superior to oral route for the induction of the endometrial receptivity. So yeah, this we already discussed. Yeah. So among this dose schedule, as we have just mentioned, either the 2 mg 3 times a day or up to 16 mg we are using. Here in this chart, everything is mentioned that how we are using and by the ultrasonic evaluation of the endometrium on the cycle day 11, 12 or 13. If the thickness is more than 8 mm, then we have to continue this progenova and addition of the progesterone. And if it is, if it is more than 8 mm, then some patients were doing the blood sampling of LH and progesterone levels. And if it is less than 8 mm, then we have to raise the doses raise the dose of the progenova, and the protocol is different. It's still increasing the dosage. If it is thickness is not increasing, then to the cancellation of the treatment. So the studies have shown with the higher progesterone levels on the day of the transfer, the single euploid blastocysts were associated with lower ongoing pregnancy rates and lower birth rates. Only few slides are left. So endometrial preparation for third-party parenting and cryopreserved embryo transfer. The studies have shown the differential in the E1 and E2 levels ratio. The transdermal E2 has been suggested to be superior to oral estrogen for inducing the endometrial receptivity and is considered to be more good. So among this frozen embryo transfer, as I just discussed, the different studies with 1.25 gram of estradiol gel, the transdermal is equivalent to 1 mg of estradiol valerate, and 1.25 gram of this estradiol gel is containing the 0.75 mg of estradiol. So friends, these are the different studies has been presented. This is from the very recent, I have taken from the JAMTA Assisted Reproductive Journal 2020. The studies have shown the inactivity cycles with oral or transdermal patches or transdermal gel. There was no significant difference in the pregnancy rates. So there is no difference in the live birth rates between the constant dose versus an increasing dose estrogen affects a fresh embryo transfer in oocyte donation cycles with oral or transdermal supplementation. So now, while we are doing this cryopreserved embryo transfer, the studies again have shown in the favor of more in the comparison of the transdermal estrogen compared to oral. So this we have already discussed. Yeah. So among this oral estrogen supplementation duration, the HRT protocol suggests supplement estrogen for up to 2 weeks. And there are different protocols and the different studies have come for the usage of this. There is one study for the prolonged estrogen treatment prior to frozen blastocyst transfer decreases the live birth, has also been by the heterogeneity has been presented. So yeah. So the studies have shown that in frozen cycles, the clinical pregnancy and live birth rates decrease with each decline in the endometrial thickness below the 7 and no significant difference in the pregnancy loss rates. So for the duration also, there are different studies has been presented. So now with the duration of the progesterone, the 2 group studies have been presented. In the conclusion, yeah. The studies have shown that warm blastocyst transfer on the 6th compared with the 7th day of the progesterone administration in HRT cycle results in similar live birth rates. So the studies, this is also has been presented in the Fertility Journal 2020, the recent data. So this we have already discussed. So amongst the summary, if we take, the studies have shown that there is no difference in the live birth rates between the constant dose versus an increasing dose of estrogen after the frozen embryo transfer in oocyte donation cycles with oral or transdermal supplementation. So friends, the bottleneck is the process of implantation. So endometrium is making of the proper endometrium is also very important for the good results. Implantation is equal to good embryo and good endometrium. So thank you friends for your interest and your time. Thank you so much.
Thank you, Dr. Antwani, for your excellent presentation. And we will postpone the discussion at the end of the session. Our next speaker is Dr. Mohga Falah, MD, PhD. He's member of the Association for Scientific Research for the IRIFIV-AISRG, Reproductive Medicine and the Endometriosis Research Group. Dr. Falah, lecturer at Karbala University, Iraq. She had a degree of Master of Science in Clinical Embryology and ART, PhD in Infertility and Clinical Reproduction from High Institute of Infertility Diagnosis. She has many publications in different scientific journals. She is going to address impact of serum progesterone value on embryo transfer timing and pregnancy rate. Dr. Falah.
Thank you very much for giving me the opportunity today to meet all the experts in fertility, reproductive medicine, and embryology. Thank you very much, Professor Iman, for this presentation. Is it okay?
Yes.
The presentation is okay?
Just the title down, impact of serum progesterone. I think you have to proceed to be sure that the slide is okay.
I will talk about the impact of serum progesterone value on embryo transfer timing and the pregnancy rate. Progesterone is one of the steroid hormones which perform an essential function in many tissues other than the reproductive system. It is synthesized mainly by the ovary and to a much lesser extent by others such as adrenal glands. Both granulosa and theca cells synthesize progesterone. I will give a few notes about the progesterone synthesis and metabolism during the follicular phase in both theca and granulosa cells. The figure at the left side shows the synthesis of progesterone during the early follicular phase. At the theca cells, by the effect of the C17 hydroxylase activity, which is only present in the theca cell, so the progesterone produced by the granulosa cells diffuse into the theca cells to be hydroxylized. So start from the pregnenolone. By the action of the 17 hydroxylase, it converted to the 17 hydroxyprogesterone. And by the effect of LH, which act on the LH receptors on the theca cells, this which present only on the early follicular phase, it is the pregnenolone also converted to the progesterone by the effect of the 3-beta hydroxysteroid dehydrogenase. At the granulosa cells, during early follicular phase, only FSH receptors are present. So the pregnenolone is converted by the effect of the 3-beta hydroxysteroid dehydrogenase into the progesterone, which in turn diffuse into the theca cells. While the figure at the right side shows the progesterone production during the late follicular phase. When the LH receptors, when the number of LH receptors increase at the theca cells, so the production of the progesterone in the theca cells also increase. And the production of the progesterone at the granulosa cells increase into the three folds. The excess amount of the progesterone, which is produced by the theca cells, may be released into the circulation and can be detected in the serum. So this indicates that the progesterone is not only an intermediate product in steroid hormone biosynthesis, but it also plays an important secretory role as a secretory product of granulosa cells in the late follicular phase. Progesterone function. There is a physiological rule for pre-ovulatory serum progesterone increase in the natural cycle, which is to facilitate the positive feedback of estrogen during an LH surge acting at the hypothalamus-pituitary level. Progesterone is an intrafollicular steroid that performs an essential role in ovulation, implantation process, pregnancy support, and maintenance. It is short-acting and elevated at 18 hours following the LH surge. In addition, it's considered as the main content of follicular fluid steroids in mammalians' pre-ovulatory follicles. Progesterone was initially being considered as a contraceptive factor through reducing the LH surge and ovulation. Additionally, it can be used as a hormone replacement treatment for women with polycystic ovary syndrome, for endometriosis, and impaired ovarian function. Progesterone is needed also for successful embryonic implantation and preparation for endometrium to support and receive the pregnancy, a natural cycle, fresh embryo transfer cycle, and frozen embryo transfer cycle. Progesterone also should be supplemented in order to enhance embryo transfer success and pregnancy rate following fresh and frozen embryo transfer cycle. Regarding the early follicular phase progesterone level, menstrual bleeding flows at the termination of the corpus luteum, which is the main source of the progesterone. So serum progesterone level at the early follicular phase should be less than 1 nanogram per ml until the start of an LH surge in the natural cycle. So any level above 1 nanogram per ml was defined as abnormally elevated progesterone level during early follicular phase and has a drawback on embryo implantation and success of IVF. The previous slide showed the level of the early follicular phase of progesterone at the natural cycle. Regarding the stimulated cycle, both IVF and EXI cycle, as we know that there is, we use the pituitary downregulation either by GnRH agonist or antagonist. Both of them affect the level of progesterone during this cycle, and this effect considered by altering the release of both LH and FSH, but mainly LH from the pituitary. So during the cycle, stimulated cycle, the type of GnRH analog employed may impact the risk of progesterone elevation. Serum progesterone on the trigger day is higher in GnRH agonist co-treated cycle compared with GnRH antagonist cycle. Regarding the cycles which is downregulated by long GnRH agonist protocol, corpus luteum can be rescued by the initial flare effect of the GnRH agonist on LH secretion. So serum progesterone level increase as a result of increased LH level. So any level of more than 1.5 to 1.9 nanogram per ml could be considered as elevated serum progesterone and may affect the endometrium and embryo implantation. And this could, as I said, that it is as the effect of the flare-up of the GnRH agonist, which lead to flare-up of the LH level. Regarding the cycles which is downregulated by GnRH antagonist, incomplete luteolysis is the most likely reason for high progesterone level early in the cycle. Studies have consistently shown significantly decreased pregnancy rate in women with elevated early follicular phase progesterone level. In the cycle, which is stimulated by GnRH antagonist, the effect of elevated serum progesterone is differed from the GnRH agonist stimulated cycle. The agonist is due to the flare-up effect of the LH, while in the antagonist cycle, it is due to incomplete luteolysis. Elevated serum progesterone defined as more than 1 nanogram per ml at the initiation of the stimulated cycle. In a spontaneous cycle following a natural luteal phase is rather infrequent event in general population. If in those patients initiation of stimulation is postponed for 1 or 2 days, progesterone level will normalize in the majority of cases, reach to up to 80%. However, pregnancy rate in this group are expected to be significantly lower compared with patients with normal progesterone level at the initiation of the stimulation. So we can conclude that the high level of progesterone during the stimulated cycle adversely affect the endometrium and implantation. This effect could be due to asynchronized endometrium with the stage of the developing embryo. Regarding the late follicular phase serum progesterone levels, the term premature luteinization should be avoided, since serum LH are not usually necessarily elevated in all patients with high late follicular serum progesterone level. I said that the main effect of high level of progesterone is due to high LH, but it is not usually elevated serum progesterone level associated with elevated LH. So the term premature luteinization should be reconsidered. The risk of late follicular progesterone elevation is strongly correlated with the intensity of the ovarian stimulation, which mainly depend on the FSH dose consumption, serum estradiol concentration, which depend on the production from the growing and developing follicles, and the number of the oocyte retrieved. These observations clearly indicate that it is the granulosa cell mass that dictate the premature progesterone elevation during the stimulated cycle, especially in hyperresponder patients. So when the women produce a high number of developing follicles with a high FSH dose consumption and high level of serum estrogen production from the developing follicle, those are high risk of elevated serum progesterone level during late follicular phase. However, serum progesterone increase can also be noted in even poor ovarian responder females who produce little number of developing follicles and low level of estrogen production, and which is mainly this related to the uncertain mechanisms. However, the excessive FSH stimulation for those poor responder females put them at risk of a high level of serum progesterone at the late follicular phase. Progesterone supplementation route and administration timing. For progesterone supplementation, there are 3 administration routes, either oral, vaginal, and intramuscular, and I think that Dr. Rito covered this topic in her presentation. The oral progesterone administration provides inadequately sustained plasma progesterone concentration. This is due to the first pass hepatic metabolism and impaired its absorption. Regarding the vaginal and intramuscular administration, it has been reported that intramuscular is more effective than vaginal supplementation, and some studies demonstrate that both of them have the same effect on serum progesterone level following supplementation. Several factors can change progesterone serum level following vaginal administration, like sexual intercourse, poor patient appliance, vaginal retention, disposition, and metabolism variations. Progesterone route of administration effectiveness can also depend on other factors such as the age and weight of the female. It can be supplemented also instead of the pure progesterone, it can be supplemented through the gonadotropin releasing hormone agonist. As we said, that it has a flare-up effect and it stimulates the production of both LH and FSH. Following the LH production, it stimulates progesterone production from the corpus luteum. Another important aspect to be considered in the progesterone administration is the timing and the duration of the administration. The timing is very important and should be synchronized with the implantation window. The implantation window, it is the ideal length of the progesterone supplementation and the growth of maximal endometrial receptivity, which can be determined by many factors, but mainly by endometrial biopsies collection and assessing the presence of menopause or other biomarkers of implantation in form of gene expression as demonstrated by the ERA test. Also, it can be determined through transferring the embryo and examine the pregnancy and implantation rate. The exact knowledge about the implantation window is the successful pregnancy and successful implantation. For most ART treatment, progesterone supplement practice is started either at the evening of the day of oocyte retrieval or at least 3 days before embryo transfer. Thus, if an embryo transfer is performed on day 3 of development, progesterone supplementation should be performed 3 days before day 3 embryo. Regarding the blastocyst stage embryo, progesterone supplementation should be started at least 4 days or 5 days prior to embryo transfer, and the supplementation lasts either till positive pregnancy test or 7 weeks of gestational age. Progesterone level and embryo transfer. Progesterone serum level is vital to achieve successful implantation and the pregnancy rate on the day of embryo transfer. And several studies investigate abnormal serum progesterone level, either low or elevated level, and their impact on embryo transfer, pregnancy rate, and live birth. In one study, a significant association was reported among positive pregnancies outcome, and the progesterone level at the day of HCG trigger has a very correlation with the implantation rate and the pregnancy. So the study found that when among the positive pregnancies and the progesterone level at the day of transfer with positive pregnancy at progesterone level below 1.5 nanogram per ml, while 9.3% of female with positive pregnancy at progesterone level more than 2.5 nanogram per ml. So from this studies, we can conclude that serum progesterone level at the day of HCG trigger is the cutoff value of serum progesterone level at the day of HCG trigger is 1.5 nanogram per ml. When this cutoff value is passed, if the serum level more than 1.5 nanogram per ml, the pregnancy rate significantly decreased. In addition, among 1,100.7 women getting pregnant when the level of progesterone level below 1.5, and only 127 get pregnant at the level of 1 to 2 nanogram per ml, and 70 women get pregnant at the level of more than 2 to 2.5 nanogram per ml. Progesterone level on the day after HCG administration. We mentioned that at the day of HCG administration, the cutoff value is 1.5 nanogram per ml. At the day following HCG administration, progesterone level of 3 nanogram per ml have been used as a marker for successful trigger when measured in the following day, which is the day after HCG. High progesterone level on the day after HCG administration, the level more than 6 to 9 nanogram per ml, with high progesterone level at the day of HCG trigger is considered due to an earlier considered as earlier downregulation of progesterone receptor expression, as well as accelerated glandular development and penopod expression, which resulting in earlier closure of the implantation window and decreased the pregnancy rate. So the level of progesterone at the day of HCG trigger 1.5 nanogram per ml, and the level of on the day after HCG trigger should be more than 3 nanogram per ml, but not more than 6 nanogram per ml, as excessive elevation more than 9 nanogram per ml lead to asynchronized lead to early closure of implantation window and asynchronized endometrial development, which in turn negatively affect the pregnancy rate. Progesterone also has a fundamental function in endometrial transformation before frozen embryo cycle. A study by Kogati showed that the importance of serum level on the day prior to frozen embryo transfer in women undergoing a natural endometrial preparation cycle. Their results indicate that serum progesterone on the day before embryo transfer in a natural frozen embryo transfer cycle below 10 nanogram per ml are correlated with significantly lower clinical pregnancy rate and live birth rate. Also, low serum progesterone level associated with higher miscarriage rate in this group of females. Similar results to the above studies have been reported, which shows that patients with artificial endometrial preparation cycle using vaginal progesterone had a significantly reduced ongoing pregnancy rate, as the serum progesterone was less than 9.2 nanogram per ml on the day of embryo transfer. So the level of progesterone during frozen embryo transfer cycle, whether natural endometrial preparation or artificial endometrial preparation, is very important in the and play a great role in the in the preparation of the endometrium and establishment of pregnancy. Why optimal progesterone level? Low serum progesterone can be a factor of low pregnancy rate. Thus, this can be more serious with patients who already have low progesterone in their blood circulation, as this considered the women with a stimulated cycle who are downregulated either by GnRH agonist or antagonist, but mainly GnRH agonist group. According to a study which has been found that certain factors affect progesterone concentration on the day before embryo transfer, which can alter the pharmacokinetics, such as age, weight, and prior history of low progesterone concentration. However, other factors such as timing of blood sampling may depend on differences in the drug absorption. So not only the stimulation, but also other factors related to the patient itself can affect the implantation rate and the pregnancy rate by affecting the serum progesterone level, by altering either the pharmacokinetic of the progesterone or its absorption. In addition, high progesterone level before eggs collection is linked with a noticeable endometrial receptivity decrease. The endometrium's gene expression profile at the end of follicular phase is certainly altered when the serum progesterone level above 1.5 nanogram per ml, as mentioned previously. Regarding the progesterone at the day of oocyte retrieval, pregnancy per transfer rate obtained in the average value of progesterone at the day of oocyte retrieval was when progesterone was 8 nanogram per ml. The level between 7 to 10 nanogram per ml, and no pregnancy with a progesterone level more than 18 nanogram per ml. Regarding the middle luteal serum progesterone levels, correlation between middle luteal serum progesterone levels were evaluated on days 3 and 7 after oocyte retrieval. Serum progesterone concentration and the pregnancy rate was observed, and levels of more than 20 nanogram per ml may predict a successful outcome. So mid-luteal progesterone level between 25 to 30 nanogram per ml are required for implantation in assisted reproductive technique cycles. Progesterone importance in successful pregnancy rate and implantation rate have been clearly illustrated. However, significant progesterone elevation prior to HCG injection can point to a desynchronization within the endometrium and the developing embryo through reducing the pregnancy rate. In summary, a successful implantation needs a competent blastocyst synchronized with a receptive endometrium, which is mainly coordinated by endometrial receptivity due to the effect of estrogen and progesterone. Thus, an optimal progesterone level is essential for successful implantation and pregnancy. In conclusion, progesterone is essential for establishing and maintaining embryo implantation and pregnancy. And also, progesterone is used for luteal phase deficiency in infertility treatment. Yet, progesterone therapy's optimal timing and dose can influence the impact of endometrial development and pregnancy. Also, low or elevated progesterone level can negatively impact embryo transfer timing pregnancy rate. Thank you.
Thank you, Dr. Mohga, for your excellent and conclusive presentation. And now, my deepest honor and pleasure to present Professor, the godfather of IVF in Egypt and Middle East. Dr. Maghrabi is head of the Egyptian Foundation for Reproductive Medicine and Embryology, EFRI. He's professor of obstetrics and gynecology, Alexandria University, training in Pennsylvania, Philadelphia in 1990. He is head of board general director of Shadbi Hospital from 2009 to 2011, coordinator Egyptian Fertility Society, Reproductive Endocrinology and Molecular Biology Interest Group, director Alexandria XC-IVF Center, Private Center. لازم بنقول بالعربي إن هو بيمثل مدرسة العطاء في مصر. School, original school of give in Egypt and the Middle East, whether for science, practice, advice. My deepest pleasure to present you, my dear professor and teacher. He is going to address protocols for endometrial preparation for frozen embryo transfer. Why should we settle for less?
Should I present or should I tear into cry? Very much. This is too much for me.
No.
Don't believe her. She is a dear friend of mine. She's a dear friend of mine. And I'm very happy and honored to present. And I would like to thank Professor Zarqawi, Professor Zakaria, Professor Nuruddin, and the Association for Scientific Research of the IRIFIV. Thank you very much. Thank you very much. Thank you all for considering me for such a prestigious meeting. My time is 30 minutes. 30 minutes. Share the screen. And I like to thank the previous speaker for facilitating my job, actually. So my talk is about natural versus HRT cycles in frozen embryo transfer. Why should we settle for less? Iman, you can hear me, right?
Yes, I hear you, Professor.
This is good. Thank you.
I tried to say this in French, I couldn't, but this is the title in French. Okay. So the incidence of freezing is increasing because vitrification is improving, because we're using more freeze-all cycles, and because of PGT. Embryos can be frozen at cleavage stage, day 3. They can be frozen at day 4, compact morility, or they can be frozen at the stage of expanded blastocyst. To prepare the endometrium, there are several methods. The most famous currently is the HRT, consecutive estrogen and progesterone, true natural cycle and modified natural cycle. And the time of transfer, as the previous speaker stated, depends on the protocol that is used. And currently, low quality evidence indicates that possibly natural cycle could be better than HRT. So the theme of my presentation is that why should we settle for this? Why should we keep doing HRT when we can do more natural cycle with better outcome? So the different methods for preparing the endometrium for frozen embryo transfer include hormone replacement treatment with or without GnRH agonist suppression. The more friendly way is to do it without GnRH agonist suppression, and actually there are no indication that suppression with GnRH agonist improves the results. Through a natural cycle, it depends on the, in women who are regularly cycling, and this depends on the occurrence of the LH surge, and it can be used with progesterone supplementation or without progesterone supplementation of the luteal phase. Modified natural cycle, when you replace the LH surge, the spontaneous LH surge, with a bolus of HCG, 5,000 or 10,000. And in this case, you don't really need to supplement with progesterone. Mild ovarian stimulation is actually mainly done by letrozole with or without HMG, and then you conduct the cycle as you are doing in regular IVF. It is not enough to consider ongoing pregnancy rate, abortion rate, and cumulative live birth rate as an outcome. You have also to consider the obstetrical outcome. You have to consider neonatal outcome. You have to consider maternal problems that can happen with different ways of preparing the endometrium. Start first with hormone replacement treatment, HRT. The two methods are either to use a fixed dose of estradiol valerate from the beginning, from day 1, day 2, or day 3, 4, 6, or 8 milligram. The common practice is 6 milligram till the end, till the endometrium improves, and then you switch to progesterone with final details that I will mention later. Or a step-up method, you start with 4, then 6, then 8, or 2, 4, 6, and there is no indication that the fixed dose is different from the step-up dose. So the classic practice is fixed dose. Oral estrogen versus transdermal versus vaginal. Vaginal estrogen is not popular, except when endometrium is very thin and you try to improve the endometrium. So the two common ways are oral and transdermal, and there is a conversion rate to give the same dose, and the oral is the most popular. The duration of estrogen priming, should we do it till the endometrium reaches 7 triple pattern, and then we switch to progesterone, even if the estrogen duration is 7 days? Mostly, you have to continue till 10 days or more. So even if you have an endometrium that is good on day 7, you have to continue for 3 more or 4 more days to achieve a period of 10 days or more, and then you switch to progesterone. What is the maximum duration of estrogen that we can give? You can give it for a very long time, 30 days, 36 days if you need. So you can change the duration of estrogen also for scheduling. You want to skip the weekends, so you can change the duration. You can prolong estrogen for 3, 4, or 5 days, etc. Progesterone administration was explicitly mentioned in the previous presentation. Vaginal alone seems not to be sufficient. Intramuscular alone, or intramuscular and vaginal. The day of starting progesterone is for cleaving embryos LH +3 in natural cycle. The duration of progesterone administration before ET differs between cleaving embryos and blastocysts, as we will show later. And the duration of progesterone after pregnancy is interesting because in HRT, it seems that you have to continue till 10 weeks, and this is also controversial. And sometimes people continue for longer times. The classic teaching is to change progesterone once the placenta takes over. So the time of embryo transfer depends on the stage of the embryo. So if you are putting back cleavage stage embryo, you put them in HRT cycle on day 3 or 4 from the start of progesterone, mostly day 4. If you are putting back blastocysts, you put them day 5 or day 6 of progesterone, mostly day 6. Day 7 is associated with lower pregnancy rate. In true natural cycle, cleavage stage is transferred on day LH +3 or 4, and blastocysts are transferred on day LH +6, so 6th day after the LH surge. In modified natural cycle, the blastocysts are transferred on HCG +7, 7th day, because with LH, ovulation occurs in 24 hours. Of course, it can be delayed. With the HCG, it occurs in 48 hours or something. So these are the different timing of embryo transfer that are associated with success in frozen embryo transfer. How true natural cycle is performed? Basal ultrasound, and then whether you use progesterone basally or not is controversial. If you use progesterone, you don't want progesterone to rise more than 1.5. Some people consider the cycle actually progesterone is high at the beginning of the cycle. Ultrasound monitoring is done day 6 or day 8 or day 9, the beginning of the ultrasound monitoring, and then you will monitor for LH, either in the serum or in the urine. Of course, it's easier in the urine, but this occurs 24 hours later than the serum. The definition of the LH surge is important because sometimes it is 10, more than 10. Some centers use more than 10 LH ml international per ml. Some centers use 17. Some centers use 20. To make sure that it is the LH surge, you need to document progesterone rise after the LH surge, or a drop 30% of estrogen after the LH surge. So this is the natural cycle. Sometimes progesterone rise before the LH surge. If it is only 1 day before the LH surge, it does not make a difference. If it is 2 days, you have to cancel the cycle. Modified natural cycle, exactly the same. The difference is that when the follicle rises, when the follicle reaches 17 or 18 millimeter, some centers 20, you trigger with HCG. You give 5,000 or 10,000. You give the minimal dose that guarantees ovulation, because higher doses will affect the endometrium and close the window of implantation earlier. So this is the dose of HCG in modified natural cycle. Now, if LH rises before you trigger, the results could be bad. So the trick is, if LH rises before you give the HCG, you shift it to true natural cycle. You don't give the HCG, because a lot of data shows that the results are less if LDH rose before the HCG trigger. So based on available evidence, FET should be timed on LDH plus 6 in true natural cycle, on HCG plus 7 in modified natural cycle. Again, they are the same exactly, except for the fact that you give HCG instead of waiting for the trigger in modified natural cycle, and this is easier or more convenient. So is luteal phase support needed in true natural cycle or modified natural cycle? You may give with in a true natural cycle progesterone with measurements or without measurements, but it doesn't make sense to give progesterone in modified natural cycle when you give HCG, because HCG guarantees that progesterone is adequate for at least 7 days after the injection. And extra progesterone will change the capability of the endometrium to receive the blastocyst or the cleavage embryo. So in a recent network meta-analysis, no difference in live birth rate was reported between true natural cycle and modified natural cycle. So we call it all natural cycle, either true natural cycle or modified natural cycle, and you are free to use according to your convenience and according to your expertise. If we include HRT now in the comparison, and this is the theme of network meta-analysis, no difference in live birth was noted between true natural cycle and modified natural cycle and HRT. Surprisingly, cycle cancellation was significantly less with modified natural cycle as compared to HRT. Why? Because there is more thin endometrium with HRT. All the people who have been working in FET for a long time know now that with HRT, you may have a slightly higher incidence of thin endometrium as compared to the natural cycle of those women that you are doing FET for. Possibly they don't receive estradiol barrier properly. Possibly the natural estrogen is better for them. So possibly there is something in the in the follicle other than estrogen that helps the endometrium. So, but this is what is happening. My thoughts are building up in the line to please move away from HRT, including myself, because I'm using HRT. So this is what I am saying. In HRT cycle, the early pregnancy loss rate has been alarmingly high in some reports. So HRT, more cancellation because of thin endometrium, and more pregnancy loss. And myself, I witnessed this. I witnessed a reasonable, a decent pregnancy loss rate with HRT despite using high progesterone levels. HRT was associated with significantly lower live birth rate when compared with natural cycle. So now if we are aiming at success, our method is not so successful because natural cycle could be more successful. And this is the last a report recently in Journal of Assisted Reproduction and Genetics in 2021. So what is the problem with HRT apart from what we've said about the reproduction? More hypertensive disorders, more cesarean section, more postpartum hemorrhage, higher microsomia, higher incidence of abortion, and risk of preterm and very preterm delivery are associated with HRT. So why? Why should we settle for less? Why should we settle for a reproductive outcome that we thought is better than natural cycle, then it turned up that it is the same or lower than natural cycle? Why should we settle for a lower obstetrical and maternal outcome as compared to natural cycle? So I started asking some of our friends, either through the internet or by phone calls. So this was from Professor Khalaf. When I asked him, do you do HRT or natural cycle? He said that we do natural cycle increasingly, and it is as effective as medicated cycle without the added cost and the effects of hypertensive disorders and the lethal outcome. So this was Yaqub Khalaf. And then I asked Bob Casper from Robert Casper from Canada. They said, now we completely natural cycle or minimal stimulation cycle through letrozole. So this was Bob Casper. I called Panagiotis from Greece, and he said, in response to, do you do natural cycle? He said, yes. We monitored natural cycle either by serum LH or urinary LH. And the indication, I asked him, what are the indications for using natural cycle? He said, all patients undergo natural cycle, except patients with oligomenorrhea or patients who live far from Milan and they cannot be followed up. I asked our friend Pierre van der Zwalmen from Brussels, do you do natural cycle? He said, no, we don't do natural cycle. So this is another opinion. He said, we perform rarely the natural cycle, and Pierre works in several centers. He said in all centers, they do HRT, but possibly some centers use natural cycle. We have a very important meeting of our department, and yesterday, Panagiotis Drakopoulos from UZ Brussels and from Greece was presenting, and I asked him, he said, mainly we do HRT, and in UZ Brussels, they are starting, UZ is a very prestigious center, and he said that they are starting to shift from HRT. And I asked him, why Draco, why do you do HRT cycle despite knowing that there is currently low quality evidence indicating that the obstetrical outcome and the pregnancy rate is lower with HRT? He said, convenience and the lack of possibility to monitor patient and the expenses. Attending was Professor Hisham Anani in the floor, and I asked Hisham, he said, since the evidence came that the obstetrical outcome is lower, we stopped completely doing HRT. So I said, what are you doing now? He said, we're doing minimal stimulation with letrozole. I asked most of my friends, the national experts, including the icon that is sitting with you, Iman, and they said they are doing HRT, including myself, of course. So we all do HRT. I looked into, I asked them 7 days ago to bring me the last 50 cases of FET in our center. And you see that the pregnancy rate actually is high. The pregnancy rate is the last column. And this is HRT. It is almost 70%. So these are the 50 patients. And it is very difficult when you have 60 to 70% pregnancy rate to play with it. We transfer either compact, we freeze at compact moruli and transfer as blastocyst, or we freeze as blastocyst and transfer as blastocyst on the same day. I'm doing this as a randomized control multi-center trial with Professor Yamani Gendi and a lot of centers in F. The preliminary data seems to show that possibly freezing at day 4 and transferring at day 5 is better than freezing at day 5 and transferring at day 5. Knowing also that it's not a problem of survival because the survival rate is more than 90% in both techniques. But we'll see when the results of the multi-center trial comes out whether freezing at day 4 or freezing at day 5 is better. So in conclusion, Mr. Chairman, Mrs. Chairman, and dear friends, FET is increasing, is improving. The method of preparing endometrium is controversial. A paradigm shift away from HRT back to nature is currently witnessed because of the evidence, although it is a low quality evidence. And why are we hesitant to follow the recent low quality evidence? Convenience, success. We have a very successful method HRT, and we don't follow up our babies. They go and deliver somewhere, so we don't see them. We don't see the problem with women. We don't see the problem with. So, but we hope that as a community with your respectable society and with EFRI, that we can do some work about this to possibly either stay where we are or we shift based on evidence. Thank you very much.
Thank you, Professor Hassan, for excellent and challenging presentation. As usual, hard to be applied, but we will try. Okay.
I'm provoking you, Iman.
Sorry?
I'm provoking you.
Okay, sir.
And Zarqawi, of course, and Zakaria and everyone.
The prestigious appreciation, of course, inshallah.
Thank you.
My deepest pleasure.
Excuse me, Iman. I suggest we take a little break for 10 minutes, perhaps. It's
okay, great.
Great. Resume just after. Okay.
Do I have to be present after that?
Yeah. If you can, if you want.
I want, but possibly
yeah.
We have a workshop in the university.
Marhaban, marhaban.
These 10 minutes are for discussion or just a break without discussion, Dr. Mohammed?
Just a break. Just a break. If you want to discuss, we discuss. Because everybody perhaps is tired, perhaps after 2 hours. I hope. But if we are strong, we continue as you want.
Doctor, I think we can take a question for Dr. Hassan because he wants to leave. Dr. Hassan?
I have to give a presentation at the university at 11. Now it's 12.
Oh,
so if you want some question, it's fine. If you don't want,
yeah.
Okay, Dr. Hassan, can you continue? No problem.
So, any questions from the floor for Dr. Hassan?
We do just Ashati. Just this, but after what I see, perhaps I'll change. Thank you.
I hope that you can do this all.
Yeah. Thank you very much.
Well, I have a question for Dr. Hassan.
Yes, please.
When you shifted from just counting on the vaginal progesterone to adding intramuscular progesterone, whether adding it on with vaginal or using exclusively the intramuscular, did your pregnancy loss rate decreased?
That's a very good question, Iman. I've been doing 900 per day for a very long time. And whenever this decreases, or the serum progesterone decreases, I face higher incidence of miscarriage. But yesterday in a discussion, we heard very strange statement that with subcutaneous progesterone, the progesterone level is lower. It's like third that of what we are giving, and there is no change in abortion rate. For me, the answer is I face more abortion if I go lower than the 900.
Even with the intramuscular progesterone, because, well, sir, what I actually, from my experience, I'm using intramuscular progesterone for long. I know it's painful and you don't like it, and it's hard for ladies, but with intramuscular progesterone daily, serum progesterone do not go down than 20.
Sure.
It's maintaining the high progesterone level, and I think it is securing this problem of early pregnancy loss. This is one question. This is one issue. And the other issue, when subcutaneous progesterone came to Egypt, it's 25 milligram. And I asked the company, is this 25 milligram enough to maintain the 24 hours? They said yes. But actually, when I measured, because I'm highly interested in measuring progesterone in HRT cycle, when I measured it 12 hours after the injection, it was something like 5 or 6, and I didn't believe myself. And when I went to literature, I found that actually you need at least 50 milligrams subcutaneous to maintain the 24. So for subcutaneous progesterone, I know it's expensive, but if the patient can tolerate intramuscular progesterone, I give subcutaneous every 12 hours. And I think we should focus if we go further for HRT before leaving it, if we focus on maintaining a good luteal function, you know, because not all the time that we can drop the HRT. It's suitable, it's time, it's suitable for all of us, for the patients, for the doctors.
I totally agree, Iman. Was this 5 nanogram per ml with subcutaneous only or subcutaneous with vaginal?
Subcutaneous with vaginal.
5 nanogram?
Yeah, it was 5 or 6 to 12 hours, and I was highly surprised. But actually, when I went to literature, and it was even, I don't like to mention the name of the company, it was the manufacturing company itself with a paper published, the graph after 25 was very lower and maintained lower than 10, but with 50, it was maintained higher than 10. And I think 10 is a good cutoff to maintain luteal progesterone and avoid early abortions, I think.
I totally agree. I totally agree.
We take any other? Sorry.
Hello, sir. Right. Nice.
Continue, no problem, Doctora.
Good. So that's okay. Yeah. I've enjoyed the session. I've enjoyed your arrangement. You're very good, and we love you, and we like you, and we love Morocco and Maghrabi. You know that.
Shukran.
Thank you very much. Thank you.
Thank you. Thank you.
Okay. We take 5 minutes or no? We continue?
No, as you like, Dr. Mohammed. And of course, I didn't have time. That there was error in connection. I want to thank you all for this, arranging this very prestigious meeting. I congratulate the Association for Scientific Research of the IRIFIV-AISRG. Is it right?
Yes, yes. Thank you.
Group, you are having a very eminent role as in Congress and international examination. And I like this, your objective about science. It's very interesting, and I think it's important for all of us. Research seeks the focus by science.
Yeah, thank you.
I think it's very important and very vital in our area.
I hope that's our objective, inshallah.
Yeah, inshallah. Should be for all.
Yeah. Good. Okay, we take 5 minutes and we resume just after with the Mustafa Zakaria, perhaps. Yeah, it's the next speaker.
Yeah.
Okay, we take just 5 minutes.
Okay.
Thank you.
You're welcome.
Hello, sir. Hi. Nice to see you.
Hello.
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 You're fine?
Yeah. How's everything at your side, sir?
Thank you. And God?
How is everything at your side? the corona patients.
Yeah. How I don't.
Yeah. I'll read. Yeah. I just asked her how is situation in at your countryside about the corona.
Good.
Okay.
Thank you. Will Dr. Iman?
Yeah, we continue, Dr. Mohammed?
Yes.
Okay.
Say Mustafa?
Yeah. So our next speaker is a pillar of this prestigious meeting.
Yeah.
Dr. Mustafa Zakaria, MD. He's Deputy Executive Director and Administrator for the IRIFIV-AISRG, Reproductive Medicine and Endometriosis Research Group. Dr. Zakaria obtained a master's degree in clinical embryology from Northwestern USA and consultant reproductive. Obtained the research fellowship certificate from IRIFIV-AISRG 2020. He had a distinct interest for oocyte somatic cell communication, embryo morphology, optimizing quality in clinical IVF, a lab member of ASRM and the ISRI with many eminent definitions for Dr. Mustafa. Dr. Mustafa is going to address duration of the effect of fertility and the insulin resistance on IVF or XC results in women with polycystic ovarian syndrome.
Thank you very much, Professor Iman. Today I will talking about the development of insulin resistance in PCOS update 2021. First of all, in polycystic in ovarian syndrome, emerging case of infertility are beginnings for an factor in Frank 1995. Okay, what's the meaning of infertility factor to 6 quickly? 14 minus 15% of infertility cases are causes of factor in women. Minus 15% of cases in factor in men. So this is slightly very important. Cases of infertility in women. In what the cases female infertility? You are many impossible cases of infertility. However, it can be difficult to exactly some of cases without any implementation of infertility. So, with middle fasting of PCOS. PCOS is very interesting in cases of infertility women. PCOS, a comment, a hormone disorder woman of a child agar. Women with PCOS is many have impacted excludes of livers in man hormones. The ovarium can be developed sample with collection to file in not regular units in recent age. Diagnosis created for PCOS. A woman has PCOS if she meet into the following three credit. A clinical, in a biological, in a human replacement, in polycystic ovarium ultrasound, the pieces on 12, the fluid on 2 to 8 mH. Why for insulin resistant with ovarium volume in up 10 millimeters. Exclude diagnosis. The option for ovarium to graze for HCS trim, insulin resistant in women with PCOS, accepted to even more comment, up to 15% present to ups in ups to women. Histology. In histologic, the receipt of gynomotic GnRH the place will round in a normal. What more improves the blood. In one collection of releasive LH and FSH to gain and transport where is the blood to ovarian. Ovarian estimation of the factor disease working together. LH and FSH. I want to explore of patient, especially of progesterone, and after ovarian to diagnose with Christ. PCOS, a cause present factor, does not mention or remember that progesterone from ovarian cells has a negative effect. Why to GRN? Keeps the factor in a normal range, which keeps in LH in FSH. The quality of PCOS to dial and increase a normal range with the dial of progesterone. So don't forget with clients with this increase in progesterone. The increase GnRH hormone was a factor of increase with LH in receive to FSH. Once LH screening, the scale are more resistant with the factor of GnRH and PICE. Then more, this is very important to contact this LH. Here in hypothalassemia with PCOS in LH is relation to high in FSH low. In a full affection with grow on physiologic, which can be in and affected. In why? In ovarian with PCOS, so they are in things that is from in ovarian. FSS is need to help to follicular in a pen. This was in can. This is correct with the power of PCOS with LH. Up to 13% to 14% of women with polycystic in ovarian syndrome. Also, you have an insulin resistant. Okay, it is well known that insulin resistant is a key factor in evaluation to development of disease. However, it's all concludes with connected now. So with cases of PCOS, in synchronous. PCOS. The level of asignogen are free in androgens. We need increase to endometriosis in significance of insulin in concentration with insulin resistant. So invariant stimulation with unconcentration in 6 hormone to be applied. Pathology of PCOS. So you have 3 groups. Group A and B. It's very interesting. Why? For classing of PCOS women was classified in more than club in OPET. More than for cycle of like in have to insulin resistant diamonds, we have to liver function test. And so this is a big problem in liver disease. Impotency also with cells in PCOS, with you have to hypertension in screening with the risk of women. So between class of PCOS in primates D. Infertility treatment in PCOS often increases decline means to correct treatment in ovarium to indicator with great method. Why of ovarium segregator. Also, the cases of include infertility problem with IVF of the perfect on treatment. And absolutely of this published in this articles within Association of IRIFIV-AISRG is very interesting on IVF in ICSI in result with women of PCOS. What was in N13? In effect in hormone deliver the notion of invariant stimulation as to insulin. This was contact with off in FSH in LH, and testosterone in androgen with the of these cases. In ovarian stimulation with women who are insulin resistant, however, to give RB SCHBG. This is very interesting. Thus, insulin resistant negative affect IVF result in women with PCOS. Hormone concentration of ovarian stimulation. In concentration of FSH, LH, and testosterone, and what's the between the group. In concentration also with some rise of FSH in centration of transfer with spherical with low in insulin resistance. Ovarian segmentation of IVF. So number one of a normal infertilization in oocytes in Fertility Education, the cycle of embryo transfer. The day of an embryo transfer, a number of implicates we are to select in insulin resistant. So, for example, in cell reproduction for embryo transfer in day 3, set of in embryo transfer in day 4. Some like in day 4, in day 5, seen with good quickly result. Insulin resistance has an effect on hormone levels, levels of ovarian stimulation. The effect in insulin resistant infertility treatment in examination in clinical, so it was found that problem in one effect of a normal to ovulation. So in hypostimulation in syndrome with in pregnancy outcome, insulin resistance does not completely its IVF result. Any study with our women with PCOS interview was low. It's affecting an FSH. Ovarian intermittent stimulation, so with increase clinically, this pattern in blood. This body, we have traced and connect the reg. So in collection of reg and follicle in 1997. Clinical result in insulin, in insulin resistant infertility women with PCOS. Yes, and you have a woman in 29 in classification of insulin resistant. So you want in the following of in CIDMA classific of as insulin resistant. How to work for an end up with children in 13 after in before minus in after minus. Insulin resistant in PCOS in how it may be case infertility. You know, what imaging of cases in infertility is a one-to-12 of result. Insulin resistant with a normal with good document of clinical fertilization of in your body for in a non-insulin resistant. So infertility woman with polycystic ovarian syndrome, this is the meaning of and very interesting with in contact with in clinical in hospital for medicine. Okay, insulin resistant in PCOS, and you have many of cases of infertility with Dr. Professor Longhorns of Australia. You can show.
If you've watched yesterday's video, you know that insulin resistance is a basic of polycystic ovarian syndrome. And PCOS is a major cause of infertility. Medical professionals are quite quick to prescribe metformin to women with PCOS. Metformin, if you don't know, is a diabetes drug that improves insulin sensitivity. I'm not saying that's wrong, but in my personal opinion, drugs shouldn't be the first resource for insulin resistance. I think diet should be. Today I'd like to discuss insulin resistance and inflammation and how it all affects fertility. First of all, when you eat sugar. And by sugar I mean not only refined sugar, I mean starches like bread, even whole grain, pasta, potatoes, sweet fruit. All of these cause blood sugar to significantly rise, which causes an insulin spike. I've talked about this in more detail in yesterday's video, but let's recap. Insulin ferries sugar into the cells under normal conditions, and when the sugar is delivered, the cells in the pancreas they sense the lower blood glucose and stop producing insulin. When we eat too much sugar, the cells at some point shut down and don't absorb it all because they're full. And that then creates insulin resistance. The sugar and insulin then builds up in the blood vessels. And the pancreas, which senses high blood sugar, sends out even more insulin. So first, the problem is that insulin and other carriers can be quite caustic and inflame the blood vessels, which then shut down receptors even further. And as a result, the level of inflammation grows, and it's a vicious cycle. And this then causes the body to bandage the inflammation, and it's doing this with LDL cholesterol. So you might know LDL as a bad cholesterol, but LDL doesn't cause the heart disease. It's at the end of the day the inflammation. If we wouldn't be inflamed, we wouldn't produce that much LDL in the first place. And when LDL is too high, because we are inflamed, then that reduces the circulation, which is necessary for proper development of sex cells and fetal development.
Conclusion. Effect of BMI to insulin resistance and successful of IVF in women with PCOS. In the collaboration of concentration in IVF outcome in women with PCOS is very interesting with IVF outcome in women. This is of honest and defiancy. Too much to insulin. In FSH production, increase in LH production. The cycle becomes so displaced in ovarians, in hot to correcting with all metamation become resist. And what does mean become resist with need ovarian with the good quality of result with an given price of pregnancy. And this insulin resistant with good quality in time for PCOS. Thank you for your attention.
Thank you, Dr. Mustafa, for your excellent presentation. Thank you for your excellent presentation.
Thank you.
And for your effort in arranging this prestigious meeting. Well, it's my deepest pleasure to present an worldwide first-class international figure, Dr. Joyce Harper. Dr. Harper, she's very eminent as being an author, academic, scientist, and educator. She's professor of reproductive science at University College in London. She's head of reproductive science and social group. She's in embryology and BGD Academy, which deliver an online certificate in clinical embryology and founder of Global Women Connected. She works in field of fertility, genetics, reproductive science since 1987, written over 200 scientific papers and published books. She started her career as an embryologist, moved into reproductive science and genetics. Now she's researching into fertility education, social aspect of fertility and infertility. She's passionate educator at all levels, and we all witness sincere efforts by Dr. Joyce Harper in every conference and in every workshop, actually. And she is including keynote and plenary lectures. She regularly appears on TV, radio, and in press. Dr. Harper, please.
Hello, my name is Joyce Harper, and I'm Professor of Reproductive Science at the Institute for Women's Health at University College London. I've worked on many different parts of fertility and genetics over the last 30-odd years, but I've now in recent years been working on the need to deliver fertility education. So I want to talk to you today about why do we need to teach fertility education. To start my disclosure, I'm partner in a company called the Embryology and PGD Academy, and we deliver hands-on workshops on various aspects of embryology. And we have an 8-module online distance learning certificate in clinical embryology for embryologists to learn the theory of what they're doing. And this is delivered by world-class experts in fertility. I'm also CEO and founder of a company called Global Women Connected, where we educate women about their health. I'm author of a book called Your Fertile Years, which I wrote for the public to understand what they need to know to make informed choices about their reproductive years. And I've worked or delivered talks for these companies over the last few years. So fertility education, I very much look on this as a prevention rather than just treatment. In the past, we have treated the cause of fertility, of infertility. So we've delivered IVF, for example, but we've not tried to prevent. And I think, me and many people think that with fertility education, we can hopefully prevent some people from coming in our fertility clinics because they've understood how to get pregnant naturally at the right time in their life, rather than wait till it's too late or get infertility and then come to the clinic. So with any disease, we should be working on prevention and not just the cure. And we haven't done that in IVF at all. So this is why us international group that are working on fertility education think this is very, very important. So I'm going to talk to you today about why do we need fertility education? How do people learn? What do they need to know? Why we have set up the international initiative and the future. So if we look at the global data on the mean age of women at the birth of their first child, we can see that this has increased quite exceptionally in almost every country. So the black diamonds are the age in 1970. The white diamonds are the age in 1995, and the blue bars are the age in 2017. And you can see, besides a few outliers at the beginning, that in almost every country, this age has been going up and is now over 30 in a number of countries and rapidly approaching age 32. Now, I'm sure I don't need to tell this audience about the risk of female fertility decline. So obviously you can see that if people are leaving it that late to have their first child, then chances are they're going to have a reduced family size. And there are going to be some people who don't even get to have their first child because they've left it too late. And we can really see that in this graph here. So this is the total fertility rates, which are decreasing globally. So we can see in every country, the total fertility rate has gone down. And the overall total fertility rate in the 1950s was 5, and now it is 2.5. And the fertility rate is the average number of children a woman would have in each country. When I was young, the total fertility rate in the UK was 2.4. So on average, women had 2.4 children. Now in the EU overall, it's 1.6. In the UK, it's 1.8. And since I've made this slide, I've just been to a conference in France and I checked the fertility rate there, and it's actually now 1.88. So it's going down very rapidly. And we can see in some countries, it's as low as 1.3. So this means that women are having closer to 1 child per woman rather than 2, which is probably what most people want. And certainly from the studies I've done, most people want 2 children. So what we are seeing is people not having the desired family size, and 20% of women in the UK are childless. Now, some of these will be by choice for sure, but I think that probably not even half of those are by choice. They're because they have missed the boat. So let's look at how people learn. So obviously people learn a lot from school, from talking to their peers, they're talking as adults. There's also some great TV programs that people watch. There's a great program at the moment on Netflix called Sex Education, which teaches people a lot about reproduction. People use a lot of social media now. I've just made my first TikTok video because a lot of young people are on TikTok. And there's a number of programs that are documentaries or on the news or on the radio or books or even professional documents from professional societies such as the Nuffield Council on Bioethics. So there's a number of ways that people can get information. And of course, the most common is to go to Dr. Google. We Google everything. Unfortunately, out there on Google, etc., is some misleading information about fertility. There's a number of reports that there's a baby panic. Why are the risks not being told as they are? They're saying that we're over-exaggerating. The idea that a woman's fertility plummets at age 35 comes from bad science. Growing number of celebrities that we see have children in their 40s, which gives women the impression that that's what they can do. And this is Professor Jean Twenge, who is an American professor who believes very strongly that we are over-exaggerating female fertility decline. And this is a screenshot from one of her videos. She says, the difference in fertility between a woman in her late 20s and her late 30s is a few percentage points. And I think those of us in the field will know that that is not correct. So what do women need to know? I think women need to understand their reproductive system from the menstrual cycle to the menopause. So they need to understand their fertility and their menstrual cycle and their fertile window. They need to understand infertility, female fertility decline, and the limits of fertility treatment. And they also need to understand the menopause. So I've been doing some work on the menstrual cycle. I think that it's important to understand the two key events of the menstrual cycle are period and ovulation. And textbook wise, we had always been taught that a woman's cycle is 28 days and she ovulates on day 14. So then surely if she's trying to get pregnant, then she should just have intercourse on day 14 and she'll hit her fertile window and she'll get pregnant. Well, I always knew that this probably wasn't the case. Women are very individual and varied, and we don't fit textbooks explanations. So I went to a company called Natural Cycles a few years ago. Natural Cycles make a fertility app. Oh, it's actually a contraceptive app that measures basal body temperature. So it can tell when a woman is ovulating, and they input this information into the app. And I knew they had millions of cycles of menstrual cycle data. And I wanted to look at the characteristics of these menstrual cycles. So we looked at over 600,000 cycles where we had the basal body temperature measurements, or in some cases also the luteinizing hormone measurement from an ovulation stick. And we found that 65% of cycles were 25 to 30 days, but only 13% were a textbook 28 days. And ovulation was nearer day 17 than day 14. And there have been a number of other studies since we've published this paper that have confirmed this data. So this is a study that's in press at the moment. These are the proofs here. That's why we've got all these numbers here. Sorry, this is our recent paper, hot off the press, looking at period tracker apps. What menstrual cycle information are they giving women? So we looked at 10 menstrual cycle apps or period trackers. They track the cycle and predict the next cycles. But unfortunately, most also predict ovulation and the fertile window, even though they are not measuring a marker of ovulation. None of the apps we looked at were measuring that. They were just looking at cycle dates. And our previous study I showed you told us that looking just at cycle dates was very, very inaccurate to predict the day of ovulation. So we did this in collaboration with Clearblue, and we designed 5 women from Clearblue's database, a woman with a constant 28-day cycle, one that was averaged on 23 days, one that was an average of 28 days but varied, one that averaged 33 days, and a very irregular cycle. Our prediction would be that ovulation was around day 16 and 17 of these cycles, but obviously it depended on the length of the cycle. So we had these black lines here are the date that we predicted ovulation would happen in these cycles. So what we can see is that these are the dates that the app actually predicted the day of ovulation. There was one app that I was very pleased didn't predict the day of ovulation, and I strongly don't think they should if they're not measuring a marker of ovulation. But you'll see here that in almost all cases, except for the very irregular cycle, the app said the woman was ovulating earlier than she actually did. One app actually always gave ovulation on day 13, always, which is obviously way off. So whether you are using these apps for contraception or for fertility to plan a pregnancy, this could cause real problems because you could miss the fertile window. So the other problem with these apps is that if you're using it as a form of contraception, then you could think you've ovulated on day 13, have unprotected sex, and you actually don't ovulate till day 17, and so you could get pregnant. So I think these apps that just look at dates do have some benefit to women. They help them understand roughly when their period would come, and it would give them some help to their menstrual cycle to know when that was happening. But I think very interestingly that they have a record of a woman's menstrual cycle, so a historic record. And this can be very useful to see if there's changes in the menstrual cycle, in the length of the cycle, how long the period is, and if there are any problems the woman experiences. To have this historical data can be really useful. And if she's starting to go through the menopause and her cycle length varies, again, the app should be able to pick up this information. So one last thing to say is that we have just finished a survey asking women how they felt about using a period tracker, and we're just preparing that data for publication now. So it's really important for women to understand their fertile window, which is 5 days before ovulation and the day of ovulation. And as I said, looking at just calendar is very inaccurate. Looking at any of the markers of ovulation, such as basal body temperature, cervical mucus, or LH, are accurate. And we did a study looking at the various apps that were classed under fertility apps and were marketed as fertility apps. And we found that most of them actually just looked at the calendar, which was really, really worrying, especially if they're trying to say they help women get pregnant. So this is a paper that's just ahead of print at the moment, but will be out any day. With natural cycles, we looked at time to pregnancy for women using a fertility awareness-based mobile app to plan a pregnancy. And so they were using the app on Plan a Pregnancy, and we looked at over 5,000 women aged 18 to 45. And this Kaplan-Meier probability of pregnancy per cycle shows us that for the optimal cohort of women who are under 35, had a cycle length variation of less than 5 days, and that logged intercourse on at least 20% of cycle days, were 95% of them were pregnant within 12 cycles. And on average, they were mainly pregnant within 2 cycles. And this shows you some of the selected exposures that had an effect on this. So if they measured their temperature frequency more often, they had a better chance of getting pregnant. If they had intercourse more frequently, BMI, we've shown in a previous study, maybe because we've got mainly patients with a very normal BMI, was not hugely effective. And obviously those women who are younger had a better chance. And I think everyone in this audience will know this, but this is important information that we have to tell the public. about the quantity and quality of eggs declining, and that women are born with all the eggs they're going to have, and that they have about 1 to 2 million at birth, and by puberty they're down to about 400,000. And something that women don't understand is that they will only ovulate 1 egg a month, but up to 1,000 eggs die every month. So by the time they get to the menopause, women have about 450 to 500 menstrual cycles. So they'll ovulate about 450 to 500 eggs, but then those rest of those eggs will die. You can do the maths from this. You can work out if they had 400,000 at puberty, ovulate around 450 times, then obviously somewhere between 750 and 1,000 eggs have to die each month. By age 37, the majority have gone. This is not a linear loss of eggs, and by the menopause, all the viable eggs have gone. We've also got the quality of the eggs. Eggs have chromosomes in a very fragile state. So as a woman ages, we increase the risk of miscarriage, increase the risk of having a chromosomally abnormal child, and we decrease the risk of conception. So I'm sure everyone here is aware of this graph showing around the age of 35, the increased risk of spontaneous miscarriage, which is mainly due to chromosome abnormalities, and the decrease in fertility due to the quantity and quality of the eggs decreasing. So some people think assisted reproductive technology will answer their problems. There's certainly a misconception that this happens. I'm sure you're all aware of Louise Brown, who was born in 1978, and this is myself and Louise on her birthday year a few years ago when she was 40. So the Obama matrix is a study that's been done by people who've been looking at fertility data for many, many years, and they used a computer simulation of a huge number of women to see what age they needed to start having children if they wanted 1, 2, or 3 children. And they predicted that if they wanted a 90% guarantee that they'd have this number of children, they needed to start at either 32, 27, or 23 years, depending if they were trying naturally. And with IVF, we can push that a little bit further, but not hugely. So it's a quite depressing read for women to look at that, for sure. Again, I'm sure you all know it's all about the egg, but this is important information. I always refer patients to the HFEA website to have a look at the data, and we can see that the HFEA group, the birth rates per embryo transferred under 35s are together, just over 30% in the UK, but then they've grouped it in 2-year batches, because as we go down, we see the live birth rate rapidly decrease, and the chance of having a baby over 43 and above is just a few percent points. But if we use a donor egg from a donor who's under 35, the chance of getting pregnant is almost unaffected by age. But the womb does stay relatively fertile. It's the egg that's the problem. And there's many reports in the media about older women using a donor egg to have their baby. They can carry the baby themselves, but they use a young donor egg. So we now have egg freezing by vitrification. I always suggest that this is plan B, not plan A. With our fertility education, we would prefer not to see patients in the fertility clinic and not to be freezing their eggs. But obviously for some women, they haven't met the right partner, or they're not in the right situation to start having a family. So cryopreservation is certainly an option. It's great that in 2021 it is an option. But I do feel concerned that there's this press to get students almost as soon as they've graduated off to the fertility clinic to get their eggs frozen. So the whole commercialization of egg freezing has really been of concern to me. And in the UK, we have up until hopefully this year, where things are going to change. At the moment, we have a 10-year limit on how long women can freeze their eggs. So if they freeze their eggs when they're 28, they have to, at the moment, use them when they're 38. but we're hoping that the government now are going to finally change this law. They have said they are going to, but we have to wait for the paperwork to be done. But egg freezing is expensive. You need multiple rounds. There's no guarantee that the woman would have a baby at the end. And there are strict regulations in most countries. And even in some EU countries, this is banned unless it's for a medical reason. So I think the menopause is great news. I think, unfortunately, women have not been taught about the menopause. So they are going into this blindly, not understanding anything about it. Some of them have symptoms for many years and then realize that that was a menopause symptoms. So I think overall it's great news. I'm sorry, I was going to sneeze. No, it's gone. But I'm doing work now on delivering menopause education. We've just done a very large survey of over 3,000 women to ask them their knowledge and attitudes to the menopause. And they clearly said they want to be educated and they want their doctors to be educated about the menopause. Many doctors were reported as not knowing the symptoms, turning women away in their 40s, saying they're too young to have menopause symptoms because you don't have the menopause until you're 51, because doctors and women don't understand that these symptoms can affect many women 10 years before they actually have their periods stop. So I think if we educate women, we can celebrate the menopause. No more menstrual cycle, no more periods, no more premenstrual syndrome, no more mood swings, and no more contraception. So I have done a number of podcasts and TV programs trying to help women understand the menopause and have a positive view to it. So in 2016, Adam Balan, Jackie Bovin and myself set up the UK Fertility Education Initiative, and we've published a paper outlining what we're trying to do, which is to improve fertility awareness. We have some animations on YouTube that we've made, which we haven't checked yet with young people to see what they think about them, but that's work I'm hopefully doing over the next year. I've done some great work with the Fertility Fest team, Jessica Hepburn and Gabby Porter, who work with artists and professionals to see how we can educate people about their fertility. And we are very pleased that with some campaigning, the word fertility finally appeared in the UK curriculum. The Department for Education said that we need to teach people about the facts about reproductive health, including fertility, and the potential impact of lifestyle on fertility for men and women and menopause. So as well as working on the UK initiative, I wanted to gather the international community together because there are some people who have done absolutely amazing work on this. There's particularly great work coming from Denmark, from France, from Portugal, and from Belgium. So I got together a few years ago an international fertility education initiative. I'm hoping very soon we'll be able to announce a major collaboration with one of the most important societies in our field. We've just had a paper out outlining the research and action that we're going to do. And we have representatives from these countries. And our mission is to improve fertility and reproductive health awareness through education. We have two research themes. We want to look at fertility, knowledge and attitudes to fertility, and we want to develop and validate educational tools for everybody. So from teenagers through to people who haven't had children yet in their later years. So we've got a lot of work to do. The first thing we did in 2019 was develop a fertility education poster. It's available from the Fertility Europe website or from Global Women Connected in a large number of translations. And we did this in collaboration with Clearblue, and we're very happy that we have this really lovely poster that people can use. And we launched this with Fertility Europe at the EU Parliament back in November 2019. So I just wanted to show you some of the studies I've been doing in this area. we've done surveys of teenagers, men and women, and also childless people in the UK. And we are just analysing some data now where we've asked young people and men and women in Greece how they feel about fertility, their attitudes to fertility, and their knowledge. So this is some of the preliminary data from the UK Women's Survey. The average age they wanted children was age 30, and we actually found the same in Greece. And they said that the main things that they are thinking about that's postponing this having children is they want stability, which is financial and career stability. They are concerned about age, but they don't want to be too young or too old, and also about lifestyle. So they want to do some things, accomplish some things before they have children. And this is a word cloud of some of the words that they came up with. We asked them why they picked their particular age to having children and what factors were affecting that decision. And the top answers were they were developing their career, they were not financially ready. But this answer here is they are ready to have children now, but some of them didn't have a partner. So they are ready now, but they don't have a partner. These are our childless studies. One of this study has been published, the study where we asked childless women. These were women who had wanted children, but were now over the age of 45 and had not had children. And we also have the study on men. So the yellow is the men and the dark blue is the women. So we asked them whether they'd actually even tried to have children, and most of them had, but some of them had not even tried because they either didn't have a partner or their partner wasn't willing. We asked them what factors were affecting having children, and for men and women, the biggest problem was not having a partner. And we asked them about IVF. Most of the women had tried IVF, but less of the men, and then why they stopped IVF. And the biggest reason for both sexes were emotional, followed by deciding that they were too old. So those papers are in preparation now. So as well as asking people their attitudes and knowledge, we also, as I said, the second aim of the international initiative is to make fertility education tools. So if you haven't seen it yet, please visit the Australian website. The Australian group led by Karen Hammerberg have had sponsorship from the government for many years, and they have this fabulous interactive website called yourfertility.au, which really makes it clear to people that are having a baby what they need to think about. So it talks about preconception health, talks about the fertile window, optimizing getting pregnant, etc. It's absolutely wonderful. In the UK, we have a very basic website at the moment, and then we've got Fertility Europe and another number of websites. But for most of these are places where people will unfortunately only visit when they're having problems. We want to really try and encourage them to visit this when they're younger, before, so that they can plan this properly. So for younger people, we have the poster, which I've also made into an animation in English. Then we've got these animations, and various other countries have also made animations. But we need to work with young people to see whether this is an effective way of delivering this information, because I feel it might not be. I think they might be a bit simplistic. So I have started to go on TikTok. It's a new experience for me, but I think we've got a lot of work to do to tailor the fertility education to our particular age group and gender that we're dealing with. So I think how we deliver fertility education to an 18-year-old boy is not the same how we deliver it to a 40-year-old woman who wants to have children. So I wanted to just mention the Denmark system. They have a fabulous clinic where it's basically a family planning clinic where people who don't want children yet but may want them in the future can go and have some conversations and some various checks. So they are looking to determine what are the most important parameters that will predict future fertility. So they've given them a color coding so that the red are really high risk things, orange and yellow are lower risk, medium risk, and green is a low risk. So obviously age, once you get over 35, it's important, over 40 even more so, etc. So they're still really trying to work out, they're moving these things around as they gather more data. So here's two of their papers talking about their clinic, which I think is fabulous, and I think we need in every country. So my take-home messages from this talk is I want us to prevent infertility. I want us to improve preconception health so that people can make informed choices. I think fertility education is essential, and people need to assess knowledge and attitudes, and we need to develop the tools tailored to different ages, and it needs to be reliable information. And we don't want people to say, OMG, I forgot to have children. So here's my contacts. I'm at Prof. Joyce Harper on Instagram, Twitter, and TikTok. And I have a website with a lot of my information, and I'm also got a YouTube channel, etc. So I hope that you found that interesting, and I hope you understand why we need to develop this. And I hope to work with those of you who would like to develop this in your country. Thank you very much.
Thank you, Dr. Harper, for excellent and very informative presentation.
I am online if anyone's got any quick
any questions from the floor, please. I have the chat with me. Any questions? Dr. Harper, okay, I will one explanation or one clarification, please. I don't know if I understood properly or I misunderstood the issue about keeping oocyte for 10 years. You ask for this, or it's already present now?
No, so the UK government decided that for freezing sperm, we could keep sperm frozen for 55 years, but for eggs, we could only store them for 10 years. It was the government decided, a very arbitrary decision. We have been fighting this for many years because obviously if a 28-year-old woman freezes her egg, she's only got 10 years and then she has to discard them. So we have been fighting this, and at the moment the UK government have said they are going to change it. So we're not sure how long, but it's really good news that they've now said they will change it.
Actually, I'm deeply surprised, you know.
Yes.
This is totally not practical.
Ridiculous.
Yeah. Even for 32 or whatever. So we are just, you know, we are doing procedure for nonsense.
Exactly. I totally agree. And what's happened in the UK is many women have thought, well, I've only got 10 years. I better wait till I'm 35 or 38 before I freeze them. And then they're having less success. It's a crazy situation. The average age of egg freezing in the UK is about 37, 38. And I'm sure that's part of the reason. So we have to get rid of this regulation. It doesn't make any sense whatsoever. So hopefully this year we'll be very happy.
Okay, and what about, you have cutoff for age for vitrifying oocyte, or you don't have? Cutoff age?
No, we don't.
And you have cutoff for transferring embryos back?
So in the UK, as far as I'm aware, it's not actually written down, but I think anyone would think very carefully when a woman was over 45. I don't think, I've never heard of anyone in the UK do IVF on anyone over 50, but I think it's a bit of an unwritten rule. But it would be very controversial if they did.
Yeah, I don't know.
The success is so low. You can see on the HFEA that at 45, it's just a few %. So to send women through this in the UK would be really unacceptable. The chance of getting pregnant is tiny. It's very, very remote.
Yeah, I think we have to go out with cutoffs for when to freeze embryos regarding age, ovarian reserve, and when to give embryos back after fertilizing the oocyte. I think we need to have cutoffs for this issue. And the other thing I wonder now, regarding ovarian tissue transplantation, is it now, you know, the IRIFIV guidelines, they said now it's not experimental anymore. So I wonder now the exact rule in UK or according to your practice.
Yeah, so in the UK, the ovarian tissue falls under a different law, so you can store it for however long you want. But I've been told by the people doing it that the success is very low. So if you transplant one piece of tissue, it will only last for a few years. And so I think we have such little data on all the time. It's only still a few hundred births in the world from ovarian tissue transplant. So I think it's a much more of an unknown for women. And I think egg freezing is safer. In many ways, ovarian tissue could be great because you wouldn't have to go through IVF, but you do need 2 operations. And if the graft is only lasting a few years, and people normally only take 2 to 4 grafts, this might not give the woman time to get pregnant.
So I don't think it should jump to oocyte and embryo vitrification. I'm surprised from this issue. And even HT guidelines recently, or the interest group, they stated also it's not experimental, but they did not recommend it for women over 36.
Yes, I agree. Yeah. No, I know. I think the egg freezing turned non-experimental really quickly. I mean, the ISRM said it in 2012. And then, when you go to talks by the egg freezing people, they're still talking about checking the success rates. So it still seems to me that people are still analyzing this, and no one can really tell us what the success rate is of frozen embryos, because they're frozen eggs. So yes. I think we still got to check this data for sure.
Yeah, hopefully. Thank you, Dr. Harper, for your excellent and very productive.
Thank you so much. I'm going to go now. Thanks. I'm just going back to the airport.
You are welcome. You are welcome again. Thank you.
Thank you so much. Thank you so much. Well done for organising.
Thank you. Thank you. You are welcome.
Bye.
Bye. Come to the last speaker, Dr. Gail Ashish, from obtained a diploma in endopelvic surgery, May 2006, University from Kiel, Germany, and also from India, radiology, from Singapore, fellowship in ART, Cleveland, USA, member of many prestigious society. And well, he is going whether for ART or for endoscopy. Our deep pleasure to have you, sir, with us today. And he will present, it will be endometriosis, an enigma treated laparoscopically.
Thank you, Professor Iman, for inviting me, as well as Dr. Mohammed, for having me here in this prestigious gathering. So before wasting too much of time of ours, I will go to my presentation. The presentation, can I able to share my screen? If someone stop this sharing screen, yeah, thank you. Okay, when we're talking about something is related to the endometriosis. The endometriosis is a disease which can be taken from the adolescent to the reproductive age group, and there are the cases where we found out the endometriosis in a perimenopausal age group too. When you're talking about the endometriosis, one should be very much worried about the diagnosis purpose, because sometimes the patient comes down to us in a little bit later stage of endometriosis. She may have the pain during the menstruation or during the intercourse, but diagnosis takes us 7 years. That is the statistical data which tell us. As being the endoscopic surgeon and doing the endoscopy for years together now, I think there are certain cases that one should be looking for the medical line of treatment rather than always a surgical type point of view. Because those who are doing the IVF as well as the endoscopy for this particular disease, it should be taken into account which cases has to be dealt with the endoscopically and which cases has to be dealt with the surgical medical line of treatment. So greetings from India, and there is no disclaimer for my talk. This is our own studies and own videos I had doing it for last so many years. So when you are talking about something related to surgery, the surgery point of view is like whether we wanted to go for it, the patient point of view, whether I really need a surgery, whether I required it, or just is a presumption that surgery will take care of each of my disease. This is a dilemma, and this is the enigma to discuss about. It depends upon, basically depends upon whether I need a surgical line of a treatment or whether I need a medical line of a treatment. Will depend upon the age of the patient, whether the patient is symptomatic, even if there is an endometrium which is 3 centimeter. And having said that, it is a symptomatic, then one should be taking about a line of a surgical line of a treatment. Then one should respect the desire of a fertility and the stage of a disease as well as the duration of the disease. What I mean by it, when you are talking about the stage, if the stage is 4 and it's a frozen pelvis, where you are going to do the operative per se is only going to relieve the symptoms of the patient. But you're thinking on the fertility aspects of it, whether my surgery or surgical step will enhance the fertility outcome, that has to be taken into account. So we'll come down to the basic things of endometrioma, whether the ovarian endometrioma requires the treatment of a surgical excision of a cyst, or whether just is a fulguration of the cyst wall, or whether we do a cystectomy, and really it improves the fertility outcome or not. That has to be talked about. There are so many studies which from 1998 till 2003. There are the weightage. If you weight the two studies, if whether I should go for operative or whether I should go for conservative line of treatment in endometriomas prior to the pregnancy, you can see these are the two groups, and in which there are the publications and papers has been discovered between the two also. So do we need to remove the endometrioma before IVF? You've seen the endometrioma and you thought that endometrium should be removed or not, because endometrioma surgery before the IVF treatment, we should be thinking of whether it is really going to improve your outcome. What is the oocyte quality? What is the control over hyper stimulations when you're talking about giving a gonadotropins? Whether these gonadotropins, along with the endometrioma, is requirement of the gonadotropins, usually it is on the higher side. Does that endometrioma per se is the person responsible for the fertilization failure or implantation failure? That has to be talked about. The rule out the malignancies, because we never know, this endometrioma may turn into the malignancy. So balancing between all these two, and whenever you're doing and the infection, what precautions you will be doing when you're going for the necessity prior to the ART is to have to one should be knowing about restoration of the pelvic anatomy. If it is a grade 1 endometriosis and you are done the excellent surgery, what I mean by the excellent surgery of is like maintaining the anatomical structure. If the uterus is retroverted or if there is a peri-ovarian adhesions, you need to understand that all of us knows that there is a tubo-ovarian angle, and this tubo-ovarian angle is not been properly maintained. You will have the infertility. The risk associated with oocyte contaminations when you're doing the OPUs, and while doing the OPUs, you have the puncture the endometrioma. Like there is always an increased possibility of having the infection in those. The location of the seeds blocking the healthy follicles, one has to be looking into it. These are the certain things which is my video where we are just doing the correction surgeries. Here, this is the chocolate material of endometriosis. We diagnosed it by doing ultrasonography. The ovaries and the AMH, that plays a role. One should be talking about when you're talking about fertility enhancing surgeries. What is the age of the patient? What is the AFC? What is the AMH? That has to be dealt with. You cannot just do a cystectomy and dropping down your AMH and AFC, which will not be a good issue for treating the patient. Definitely a rectal endometriosis and has to be excised, because there are the reports where the rectal endometriosis, if you are doing the proper job, the spontaneous conceptions are there. But see, whenever you wanted to do a restoration of the anatomy, this ovarian fossa readhesions and the peritonectomy is the answers towards it. I'll just fast forward a little bit of the video for our understanding. This is the way where we just restore the anatomy, because if you see, the rectum is freed from the posterior surface of the uterus, and the ovarian and the tube-ovarian angle has been restored. But mind saying that this always not the case. Though you have to be concerned about what I was talking about is the AMH. Concern regarding her reliability is again the issue. When it is not the reliable that much, because we know after the endometrioma surgery, the AMH drops down and it rebacks in 3 months. But what then? What is the specific biomarkers? The specific biomarkers can be AFC. AFC do not the same. And mind well, when you are doing the cystectomy, there are certain principles to follow. It is a blunt dissection. When you come at the cortex, don't use a much more of the bipolar coagulation. It is advisable to do a hydrodissection in the proper plane. And if you are in a proper plane, you will not going to have the more excision of the wall. And definitely, you are pathologist. You have to ask the pathologist whether it is only endometriotic cyst, or you can find the antral follicle along with it. Because if I'm just pulling the cyst wall, there may be a possibility that along with the cyst wall, the antral follicles may come up. And this was the take home when you're talking about the endometrioma, whether the ablation or whether the excision. Because mind well, my friends, the endometriosis is a disease of recurrence. Always you cannot assure the patient that I've done a surgery and it is the last surgery. No, the patient will come back to you with the recurrence of the endometrioma. Then what to be done? So these are the certain things, like art of a surgery. The art of a surgery is like to be in a proper plane. Don't be just do a surgery per point of view. You have to think that the fertility aspect of the patient. And when there is a defect is more, you can just think whether the hemostasis is proper or not. You need to understand that that if there is a defect is more and that is bleeding, instead of coagulation, you can just do absorbable sutures. And you can suspend the ovaries. There are the papers that all of us know that you suspend the ovaries to the anterior abdominal wall, the chances of readhesions are less. So these are the certain principles that you have to be taken into account. Then coming down to the what are our guidelines, all of us knows that. So I will not go into the details of the guidelines. It's available everywhere. But mind well, if it is less than 3 centimeters, no need to do a surgery unless and otherwise it is a symptomatic patients. If there is a symptomatic patients, it has to get operated. And the better way to operate, just to do a prior workup with your AMH, that will be a good things to be done. So how many surgeries you will damage? The accidental removal of the healthy ovarian tissue, and which will cause decrease in AMH, what I was talking about. So it's better to use a minimal electrocoagulations, and per se, you can use a point coagulation. So see well, do a thorough cautery and then come out. The endometrioma and ovarian disease, this I was talking about, more difficult to document the same with the AFC. But if you are having said that, the ovarian reserve, if you wanted to compare between the head-to-head and your surgical skills, it is better to compare with the AFC rather than the AMH. The stage 4 disease, the coming down to the what we can think of stage 4 disease, and she's having the fertility per se. She is having the chronic pain. She's having the pain while having the intercourse, and that could be something we call as a DIE. DIE definitely required the surgical experience of a surgeon to deal with. Again, it is a nerve sparing. One should be taking care of the hypogastric nerves and nerve complexes in the parabolic region. The segmental resections as well as the disc excision, there are much more debates about it. But mind well, my friends, if it is more than 2 centimeter, the nodule, it is better to excise rather than the disc excision. The shaving has a beautiful role. When you do a rectal shaving, it causes 80% of the pain relief, and it's the least complications, because when you have a segmental resections, there is a leak and all that complications. Those who are a laparoscopic surgeon in August gathering, they must know, and they are knowing about it, what are the complications of this particular procedure. So this what we had the patient is about, and the basic principles is the sigmoid mobilization. There are the 4 steps. Those who are just doing their endoscopic work, these are the 4 steps one should be following. You have to do go from the virgin area to the adhesive area. You have to go from the sigmoid mobilization. Do first is a mapping of the ureter, because ureter is our good friend. And if your ureter is in our vision, your least bother about anything is going to get damaged. And then go in the parallel dissection. You dissect parallelly, because ureter has a mesoureter, and mesoureter is a beautiful to dissect about, and you can take care of the ureter in that particular plane. And if you start going dissecting plane by plane, mind well, these are the oozing that is going to happen. Don't worry about the bleeding part, because endometriosis is the part of inflammation. So you can definitely have the bleeding when you are going to dissect it. So don't do a coagulation much. Dissect more and then do a point coagulation. Dissect ureterolysis, then go to the plane of the ovarian fossa, do ovarian fossa adhesiolysis, and then go for your pararectal spaces. The pararectal spaces is a beautiful plane where only the point of a nodule which is going to stick to the uterus. So if you dissect between the two pararectal space, what you are going to address is the rectal nodule, which you can definitely take care of. I'll just fast forward my video. If there is a time, I can show, or I can just fast forward it. And this is the where we are just, there is a kinking of the ureter. Take all the disease out. Mind well, if you are leaving the disease behind, this woman will come down to you with the hydroureter again. So it is better that the first surgery should be the complete surgery, and it should be a last surgery for that patient. And what the literature says, the symptomatic woman with the severe endometriosis, repeated IVF implantation failures may benefit from the extensive laparoscopic surgery. So here the laparoscopic surgery plays a role. But mind well that the another thing has to be considered upon. You have to do a stimulation prior to the surgery. Get the eggs retrieved, make the beautiful blastocysts, cryopreserve them, go for the surgery, clear the anatomy, and then do a nice ET. So these are the certain things that I will not go into the details of how the oocyte has been hampered in endometriosis. All of us knows that if you compare the normal woman with the woman having the endometriosis, is not only the anatomy that is defective. It's a defect in all over things. So the good ongoing pregnancies, we need to have the two number of M2 oocytes and the healthy composition of the mitochondria in the oocytes. In endometriosis, we know there is a low mitochondrial DNA content of the oocyte, so we're not having the same oocyte quality as that of the normal woman. So what is the take-home things? Let's know the evidences. One should be doing the oocyte freezing. If the patient is young, you can definitely have the younger age patients do offer this particular protocol. Survival rates, you have to think about the recurrence things and all that thing. The live birth rates and the age category of these patients. These are the certain things which were compared, the unilateral surgeries, bilateral surgeries of endometrioma and the no surgery group, where you clearly understood if there is a bilateral disease, the M2 oocytes are going to have a much more outcome. If the younger the age group, it's better to do the operative rather than the older age group, because we know in the older age group we have the lesser M2 oocytes. Always they have the lesser AMH and lesser AFCs. So if the patient is of the older age group, it is better to go for an ART procedure first and then the laparoscopy in the later half. So the fertility preservation gives to the patient with the endometriosis valid treatment options to help their reproductive outcome. These are the certain things, that's the steroid metabolism and things. To end my talk, I definitely like to quote the think twice and be wise. So when you are thinking twice as a treating physician, as a treating clinician, it is better to think twice about the patient. Every patient is different. Every individual is different. Make the call according to the patient's. Thank you, organizations and organizing team for inviting me.
Thank you, Dr. Kale, for a very excellent presentation. And now I think time for discussion for the speakers, okay? Dr. Zarqawi, we start the discussion? Okay.
good. Thank you. Thank you very much for with you. We must do surgery for endometriosis when the age of patient permits this kind of surgery, and we have a good results after without IRT and after IVF. So I'm okay with you.
I'm not that okay. I'm not that perfectly okay. We will discuss. Well,
waiting for the others.
Questions from the floor? What's messages from the floor? Dr. Mustafa and the IT. Is there any coming questions from the floor for the speakers?
Okay, Victor, you are welcome. What's your question?
Do we have? Well, I think someone sent a question, but it's in French. So please do the translation.
Okay. I will send Dr. Zarqawi. Can you translation for English? But
from Mary. Mary sent.
Where is the question?
In group WhatsApp.
Okay.
Yeah, now it is in English. I have it in English. To Dr. Yeah, I have question to Dr. Zakaria.
Okay.
Okay. How much insulin resistance in polycystic ovary syndrome? What is detection of insulin resistance? Let's start one by one, please. So the first question is how much insulin resistance in PCOS?
Okay, it's good. Good question. In PCOS, for comment of insulin resistance with in women in reproductive age is often the contacted by insulin resistance. This is first one. In group 1 for infertility problem with an M for students in successful with agar SMART. Why is this in agar spam of PCOS? This is very important for insulin resistance. This is why women with any insulin resistant with PCOS.
So I think what is the incidence of insulin resistance in PCOS? I think this is maybe also needed. And how much more? I think you stated in 50 or 70 or something.
No, for insulin resistant in women, was diagnosis with PCOS.
What is the detection of insulin resistance? So I think they mean how to detect insulin resistance in PCOS.
Okay. Exactly, with predilection of women with PCOS in accumulation for up to 1 of 40% of insulin resistance. Also, women with need of insulin resistance with PCOS.
And how to detect insulin resistance? I think also they need this. How to detect it? What test you will diagnose insulin resistance with? How can you diagnose it?
Okay, for the detector, you have increase of development of hypertension for type 2 in diabetes, for in coloring, in raping disease, for all in hypoinsulinemia for PCOS. Because why? This is the first question. Really, it's hypoinsulins with you have been to found what's correct with the profile. So with increase insulin resistance with PCOS, the factor of rage. This especially for women.
I think also there is increased fasting insulin level with insulin resistance, Dr. Mustafa.
Yeah.
So insulin resistance and the increased risk of PCO, and how many patients with PCO have insulin resistance already, is the fact is that these women are at increased risk of having the metabolic syndrome. Okay, I think this is more or less comment. Any questions? I received only this one. Any other questions from the floor? Well,
only one, so excuse me, one question about progesterone transdermic. There is no transdermic progesterone, it's only intramuscular or to take Peros. There is no, or intravaginal, that's all. We don't have transdermic.
Yeah, maybe they mean the subcutaneous, but it's not.
Subcutaneous, progesterone, it's estrogen, but not progesterone.
Subcutaneous, I think so.
Yeah. Okay. Any other questions, Dr. Zarqawi?
No, it was the only question in French I translated. That's all.
Okay. So I have. I think we. It's okay. It's time. I have questions actually for the speakers. Okay.
Okay.
We have time. We have time already. We are late. We have time for questions, or we don't.
Yeah.
Okay. So for you, Dr. Zarqawi, thank you, of course, for your excellent presentation. I just wondering about, of course, I know now you are highly expert in endoscopy, but for the ASRM latest recommendation in unexplained, you know, in the recommendation 2015, they recommended doing laparoscopy with unexplained infertility for 3 years. But the last update in 2019, they just dropped the laparoscopy and they said it's not a must to do laparoscopy in unexplained infertility. But of course, I'm a clinician and I only do ART. And I think, you know, and based, of course, I know you have high experience in this. Would you have certain list of patients you will insist on doing laparoscopy for this unexplained? I don't think we should have it routine according to the ASRM 2015. But I think there is category of patient we all feel as clinicians that these patients might benefit really from laparoscopy. So can you have this list of patients, this certain indication you insist on doing laparoscopy for?
Okay, the young people, the young women, which there is no other explanation to her infertility. We have tried all the medications, and when we don't have anything above, I do exploration by laparoscopy, and I find often the endometriosis or adhesions. And after, there is 40% of spontaneous pregnancies. When I don't have anything, when I don't have a pregnancy after 1 year, when the women are young, and we have an AMH, good AMH, I stay 1 year, and after 1 year, I go to the IVF. But when the women are more than 30, 36, 37, I go directly to the IVF.
You haven't seen cases of good pregnancy after also hysterosalpingography?
Yes, without anything. Yeah, I see it. And now we are doing biopsies with the in Paris laboratory to see what's the problem in the endometrium. And we find hypoactivation of natural killers or hyperactivation of natural killers in the biopsies. And we hope that when it's hypoactivation, we must do biopsy, or when we do hysterosalpingography, we touch the endometrium, and we do more level activation of this inflammatory, and we have the cycle after pregnancy. Perhaps this is the explanation of this.
Very interesting, Dr. Mohammed. Thank you so much. Dr. Yacoub, already we had him, he left. For Dr. Santwani, for the endometrial preparation, Dr. Santwani is with us?
Dr. Santwani was absent here. You can hear.
She's here?
Yeah.
Okay. Again, any questions from the floor for Dr. Santwani? Okay. So, Dr. Santwani, you already made a very elegant review about the frozen transfer, but the issue I raised with Dr. Maghrabi, which is the vaginal, using only exclusively vaginal progesterone for 100 milligram twice per day. Actually, there is very interesting study for Laparta stating that with this low vaginal, exactly 400 milligram every 12, they find in 30% of cases low progesterone level, lower than 9.2, and had high apportion with these cutoffs. So I think if we, and they recommended rescue dose, whether with intramuscular progesterone or with subcutaneous. I don't know your experience with this. You are using all the time, using vaginal, and you have data about the high incidence of early pregnancy loss with these cases, or what's your comment?
There's no.
She's not here.
Probably she's.
Excuse me, but there is 3 years I dose the progesterone level for everyone before transfer, and I see this is because in Morocco we don't have progesterone. We don't have just progesterone vaginal. That's all we have. So when I have 30% that the level is less than 9 or 10 milligrams.
Yeah, you are talking about fresh cycle or frozen cycle, Dr. Mohammed?
Frozen cycle, frozen cycles.
Okay, and in these cases with 30% of cases, which is it quite coincide with literature, you have, what is the prognosis of these cases?
It's we don't have pregnancies with it, and we are collecting for perhaps 1 or 2 to talk about this.
So this is what Dr. Laparta said, and it goes also with our finding, because actually when we went, really when we used to count on this vaginal preparation, we had high apportion, and actually we published the study many years ago comparing between using letrozole for preparing in frozen transfer versus HRT, and early apportions were higher with HRT only when we counted on the vaginal progesterone. So I totally agree, and now I think there is rising number of studies addressing the same issue. So for Dr. Mohga, Dr. Mohga is here.
Yes, Professor.
Okay. Any questions from the floor? Yeah, now I hear you, Dr. Mohga. Any questions from the floor for Dr. Mohga? Okay.
Okay. Dr. Mohga is here. She here.
Sorry? So now, yes. No, this is for Dr. Kale, okay. Amina, he doesn't answer to the questions. We have a question for Dr. Kale. So for Dr. Mohga, Dr. Mohga, you said about the high detrimental level for progesterone on day of HCG, okay? Which is spreading in literature, but actually there is one very challenging study by Dr. Boulisos when he measured the progesterone on day of trigger 4 times across the day, and there have been marked fluctuation in progesterone level across the day, being higher in the early morning and lower in the afternoon. So I don't know if it needs for all of us to revise the whole thing again and to fix the time we take for progesterone value. This is one issue. I don't see, I need to know your comment. And the other thing is the issue of having one detrimental cutoff for progesterone 1.5. I think this cutoff, it has to vary according, and actually you elegantly demonstrated that this cutoff varies according to the E2, the rising E2. The cutoff for detrimental progesterone, it would vary between low responder, mid responder, high responder, according to the rising E2 level. So I need to know your comment about these two issues, please.
Yes, Professor. This cutoff value differed in poor responder and hyper responder female. Some studies showed that in hyper responder female, the cutoff value could be elevated to 1.5, 1.9 nanogram per mol at the serum progesterone level at the day of HCG trigger. As it is this elevation in the progesterone level mainly depend on, as I said, on granulosa cell mass, FSH consumption dose, and raised E2 level. So this cutoff value can be ranged from 1.5 to 1.9 nanogram per mol.
Yeah, I totally agree. I totally agree. And what about your comment about Boulisos?
Regarding the first comment, some studies show that there is a fluctuation in the serum level of progesterone, and also not only during the day. Only other factors can affect it, as studies show that the age of the female, her weight, can also affect the level of serum progesterone. So I think many studies should reconsider the level of serum progesterone at the day of HCG trigger and should be revised.
Yeah. I think I totally agree, and thank you for your presentation, because I think it's one of the hot topics, but we have to re-emphasize on other points, as you already mentioned.
Thank you very much.
Thank you. Dr. Maghrabi, already we asked him. Dr. Mustafa, any questions from the floor to Dr. Mustafa?
No question.
Okay. Dr. Mustafa, for your feeling of importance of insulin resistance, you give a sensitizer in routine?
Okay.
Or what is from the practical point of view, you give metformin or whatever? If you give it for how long before the cycle? At what dose? What's your practice?
Okay, this for insulin resistance, this is very important. I will talk about in conclusion for my slide, because why? For BMI, in insulin resistance, we're successful with IVF women. This is very interesting. With PCOS in correlation of the spice with women. This can you outcome in results in for clinic in for hospital. This will give you a good quickly and good result. PCOS in contact with insulin resistant without also woman is on insulin resistant. Because why? You have two group. Group 1 for insulin resistant and group 2 for insulin resistant. This is why with contact with PCOS. PCOS with emphatic of insulin resistant without ops in IVF outcome. This is for women, especially. This definitely with study in University of American neuros to give me for result in insulin resistant with PCOS. Now for update 2021 for good result for insulin resistant in contact with PCOS without the factor of risks to insulin resistant in with PCOS in infertility and explained infertility for this woman. So with go to big information about new result into update 2021. This for conclusion of this insulin resistant with PCOS.
Dr. Mohammed, you need to say something? Dr. Mohammed Al-Qawi?
Here in Casablanca, we give metformin for the patients with PCOS, just to lose the poids,
to lose weight, or what you mean?
Yeah, the weight. Yeah, thank you.
So in what dose? You give it for what dose and for how long?
It is 850 a day.
Once per day, or
twice
per day? Okay.
Yes.
Okay.
Yes.
Okay. Thank you.
Thank you.
So now for Dr. Kale. Okay. Any questions from the floor for Dr. Kale? Okay. Dr. Kale is with us. Dr. Kale?
What for him? One question about what kind of energy he used. What kind of energy you use to do surgery for endometriosis, deep endometriosis, or this cystendometrium?
I used a bipolar, RB bipolar for cyst endometrioma, and in a DI, I used a harmonic scalpel because I feel it's a good dissector tool, and you dissect it more precisely. So I use that.
Yeah.
There is other question: is AMH necessary before you operate ovarian endometriosis? This is
of course. I think that is the mandatory thing that one should be doing AMH prior to the operative, because you need to counsel the patient that if the AMH is low, it's better to do ART treatment first and then go for laparoscopy. And you should be in your hand something in a black and white paper, which will tell you that your surgical per se is not causing a deterioration of the fertility outcome.
Okay. Regarding removal of regarding removal of endometrium, okay? This is my inquiry. Well, we know all HRI guidelines. Actually, there is increase in live birth rate after endometrioma excision, spontaneous. As long we do it in young age, in short duration of marriage, in good ovarian reserve, we have to counsel and of course, in the presence of excellent endoscopist. So the damage is very low. So we know we have to counsel our patient for this. But for removing endometrioma before ART, what I know is that there is no evidence suggests that removing endometrioma before ART improves live birth. And actually, there have been meta-analysis, systematic review for Hamdan in Human Reproduction Update. We all about it. When they proved, based on many studies, that removal of endometrioma before ART does not improve live birth, but it does decrease ovarian reserve. So for myself, I would recommend endometrioma excision with good endoscopist like yourself, like Dr. Zarqawi, but in the early beginning. But before ART, I don't think we need to remove it before ART. What do you think?
Only to removal of endometrioma per se, what rightly said by you, is doesn't improve the live birth rate. I totally agree upon it. But the thing is that when you're talking about the endometrioma, when to operate them. The endometrioma, when to operate when she's having the symptoms. Like if there is a rupture endometrioma, she has a chronic pain, or where you are thinking of a malignancy, where you need to take some biopsy to produce the report of it. Then you need to operate her. Secondly, if you are doing a transvaginal scan by yourself as a ART specialist, and endometrioma is coming in a way of a healthy follicles, you cannot operate. I know you need not to operate that endometrioma. You can use a different needle to aspirate the healthy follicles and then do it. But there is always a chance, always a fear that the chances of infection, because you are doing it transvaginally OPUs, the chance of infections are you need to be worried about, and prophylactic antibiotic should be way forward in those situations.
Yeah, I think, and actually this is the literature. When we are talking about incidence of infection after retrieval, it's very low, but it's reported especially in cases of endometrioma. Therefore, in this particular group of women, routinely we give a preoperative antibiotic, and it works great.
Yes, myself.
So I think the indication of suspicious malignancy coming in the way, it's very low percent of patients which might need this procedure. I think lower than 5%. So, but again, with this, in the other way around, with shorter duration of marriage, with excellent ovarian reserve, AMH exceeding 3.5 or something, I think we offer these ladies so that we will not lose the chance of having a spontaneous pregnancy without going to ART. And to go to the excellent endoscopist. I think this is very integral, and I like the NICE guideline 2017, where they insisted on doing the procedure with first-class laparoscopist, so that we will do no harm for the ovarian reserve.
One shot.
Yeah, and I say,
very important.
Think that it's the last surgery for that particular female.
Yeah. So I think there is no any questions else from the floor. Well, I think we came to the end of this very productive session, hopefully. I thank you, ladies and gentlemen, for your kind presence. I thank Dr. Zarqawi, Dr. Mustafa, all the distinguished speakers for arranging this prestigious Congress, and my best wishes for a very successful conference and examination, inshallah. Thank you.
Thank you
very much. Thank you.
Thank you. Have a lovely day.
It's a pleasure.
Thank you very much, Dr. Iman. Thank you very much, Dr. Khail. Thank you very much, Dr. Zarqawi. This is first Congress for Association of IRIFIV-AISRG. This you are welcome. Your another Congress. This for your home in Morocco, in Casablanca. This you are welcome to Egypt. Welcome to India. Welcome.
This next time.
Big happy for this #1 of this Congress. And also, Dr. Mujah, you are welcome to Morocco. This is very interesting with you for contact to new articles, new work for inshallah in future. Thank you all team. Inshallah. Thank you all team for this Congress, for this presentation, all of them. I'll wait for again.
Thank you. Thank you.
Goodbye.
Bye.
Goodbye.
Thank you very much.
Yes.
Goodbye.